Kala, we are waiting for you for countdown.
एक सेकंड में क्या वीडियो ऑन कर दो फिर देख।
Hello.
नमस्कार मैडम।
Hello, Dr. Gayatri. So good to see you, everyone. Yes.
We are live now, ma'am.
दोबारा ज्वाइन करो ना।
Babita, we are live. Babita, we are live.
Save driving mode, please. Save driving mode task.
तो फिर
Babita, we are live.
यस मैम, जस्ट अ मिनट।
Yes.
Good evening to all esteemed faculties, delegates, and a very warm welcome to our societies of Greater Noida, Muradabad, Bareilly, Bulandshahr, and Shahjahanpur. A very warm welcome to our series of E-Classic for Clinicians, PPH Skill and Drill, organized by Dr. Sadhana Gupta, Co-Chair Suffolk NCD Committee, and Foxy Presidential Candidate 2023. Any practicing obstetrician cannot stay away from the wrath of PPH. It comes like a bolt from the blue, and at times, especially when we are not prepared for it. Of course, with the use of uterotonics, especially carbetocin has been a great boon for us, but still there are times when we do face PPH. And in this era of consumer era, we should all be aware of the different options available for the management of PPH, be it the bundle approach by FIGO or the use of tranexamic acid, use of compression maneuvers, uterine balloon tamponade, all the devascularization procedures, SR cannula. Yes, it sounds very promising, and internal iliac artery ligation. So we should all be, at least whether we are able to do it perfectly or not, at least we should all be aware and keep practicing so that we become perfect with it over the course of time. So before beginning the webinar, let us all join hands and remember Ma Saraswati, the goddess of knowledge, and also join for the lighting of the lamp. And internal iliac artery ligation. So we should all be, at least Saiti? So now it is time to invite Dr. Sadhana Gupta, the key organizer of this program. Madam has been working tirelessly since past so many months to spread this knowledge of PPH to each and every society of Foxy, from east to west and north to south. Madam is very humble, hardworking, and a hardcore clinician. She is co-chair Suffolk NCD Committee and Foxy representative to Suffolk 2018-21. She was Vice President Foxy in 2016 and ICUG Governing Council member from 15 to 21 and has received the Best Governing Council Award 2021. She is corresponding national editor and peer reviewer, Journal of Obs and Gynae and Journal Suffolk. Ma'am has conducted so many conferences, workshops, CMEs, and she is recipient of 3 times Korean Award for the Best Scientific Research Paper, 4 times AICOG Research Paper Award. She is author of so many books, The Cesarean Vaginal Delivery, and a comprehensive book of Obs and Gynae. Madam has received award Foxy DC Datta Prize for Best Foxy Publication and Manual. She is recipient of NA Shailaja Pandit Award for Women Empowerment Economic Times Award for services in COVID times. A very warm welcome to you, ma'am. And I would request you to invite and introduce our chief guest and guest of honor.
Thank you, Babita and Chitkala here. So a very warm welcome to yet another series of E-Classic for Clinician. And we are taking in this E-Classic for Clinician, why this name and why this series? So why this name? Because we, the seasoned teachers of teachers like Dr. Anuradha Khanna and us, like teachers all over the country are concerned about this, that we are losing a little bit the very strong foundation of the basic and the classical teaching. So many times there are issues because the people are like the students or MCQs and they are getting for the competitive examination. And we are really building like a castle on a very weak foundation. So E-Classic for Clinician, because it makes every person, every doctor, every clinician a very, very alert, watchful and the intelligent clinician, because we focus on the very, very strong foundation of the classical teaching in OB-GYN, which pertains right from basic to the all management, and it is supported by all evidences and the recommendation. Why these topics? So we give a lot of topic to our society's president secretaries like postpartum hemorrhage, cesarean, adolescent health, and the gynecology. But it is really a matter of deep interest that many societies always want to have the PPH skill and drill workshop. And that speaks volumes about it, that how still we have come a long way. I have given around 30 years with pan-India workshops, programs, project for this prevention of PPH and the management of PPH. But still there is a lot of need to do today. The teachers who are doing work in the tertiary care facilities, Dr. Richa is with us, Dr. Anuradha Khanna, what we say, Dr. Saroj Singh, who has been my like immediate senior, always say they are getting, Richa will like approve, like give this thing that they are having daily 4 or 5 referred cases of PPH in Agra, St. Medical College, Agra. And that's why it is so important. Beside this, a lot of medical legal issue. So we are taking not the basic skills which should be learned by everyone and which should be rehearsed by everyone. So with this, a brief introduction, and I have a big gratitude for a lot of cooperation, contribution, love and affection for all these programs, be it a physical, be it a person. With this, it is a real great pleasure to have Dr. Anuradha Khanna, teacher of teachers. What we say, we take it like she is an encyclopedia of OB-GYN, and always like whenever you meet her, she had a very strong basic teaching, and she is the most updated person. No thing which is futuristic medicine, which is a present challenges. Dr. Anuradha Khanna is very well versed, and she has her unique way of communicating knowledge. Madam has been the ex-head of the Department of Obs-GYN, the premium institution of our country, that is the Banaras Hindu University, Varanasi, ex-president of Vox, and she is the president of UP chapter of SFM, president Varanasi Menopause Society. At the moment, Madam is president of UP chapter of Obs-GYN, organizing secretary of a series of conference, a lot of EPCOG, journal conference. Just now we had the very wonderfully organized North Zone Yuva Foxy, and we had all darshanam of the Kashi corridor. Examiner, a thesis guide, and a very ardent researcher. She has been awarded Fellow of Academy of Medical Science, which is one of the like a very prestigious award of our country. DJ Mukherjee IMA awardee, WHO Fellowship awardee, UICC Fellowship awardee, Indo-Hungarian, Indo-Netherland awardee, and a lot of papers and the publication. Guided 42 MD theses and 4 PhD theses. She is a real wonderful researcher and a real guide to the generation of OB-GYN, and delivered many oration and guest lectures. And above all, she is the person whom we always want to have her company her way of thinking, very, very spiritual, very, very righteous person, a wise person who always like differentiate between right and
so
wrong.
much.
So, ma'am, thank you very much for your precious time, and we wish to listen to you and with your pulse of wisdom.
Thank you so much, Dr. Sadhna Gupta. Before saying about the PPH, I would like to say that you are also a very wonderful person, working so hard for the campaign of your president to be president in Foxy. And I'm telling you, we all UP persons, we love you, we want you to be there presenting us as a Foxy president. So this is my special from core of heart, my best wishes to you for your having the winning the Foxy President Award. We all are with you, I'm sure of it. And now I will like to sing about the PPH that we can't say which one is low risk, which one is high risk. We have to presume that each and every patient is a high risk. And whenever the patient has entered in the labor room or your antenatal care, we have to go for the basics. As you said me about, I'm a person of basics. Her hemoglobin, her risk criteria, and whether she's picking it up or not, if she was anemic, how many, but all the risk factors, we know about this. And in spite of that, even primary may have PPH. So we have to take care that our, as you said, the Dr. Babita has said about the bundle should be there. Our all residents, our old nurses, the staff, they should be trained again and again every month that once the patient has entered, what to do and how to take care. And once the PPH starts like that, the IV bore 16 days is the most important thing. An arrangement of fluid, of course, is there. An arrangement of blood, which we remember hemorrhage 111. That means we will go for Paxil, we will go for the FFP, and we will also think of platelet, because what is the CBC is not in our mind. What is a platelet, what is a coagulation profile is not in our mind. The things start like that and we are helpless, looking like helpless. So all these things are very important to do what already Babita has mentioned many things that we should know these things. And I will request all of you, those who are listening, that step of de-vascularization is a very thing good, important to get it done. But we all should know about the internal iliac ligation. And there are many techniques. One technique I found to be very simple, discussed with Dr. C.N. Purandre, that you pass a thread or this catgut or whatever suture is with you, or vicryl, from one side to other side of the common iliac, because common iliac is very big and this common iliac is not going to be perforated, no chance of venous injury. And then you imagine on any side, then the side which is on the pelvic wall, there you will not do anything and you will come on the medial wall and you will get it delivered from the internal iliac. So this is a simple thing. Now don't bother whether you are going to ligate the anterior division, posterior division, whatever it is, doesn't matter. I have done this technique and posterior division has been ligated, but there was no ischemic necrosis. Already the vessels will be formed and we should not be scared, because we should know a simple technique to save the life of mother. This is one point I would like to tell you. And whenever your case is of placenta previa, creta and theta, you are going to handle, please give midline incision. Or previous cesarean is there, suppose midline. So incision matters, your approach, and what drill we are doing is actually making our mind always again and again that these things may happen and we have to go like this. And that for that you have to have flow chart and repeat again and again. Dr. Richa Singh is there. She is in medical college now. I'm retired, and she will be taking care now. Babita, I think you are in practice, but your assistant, whosoever is there, they will take care of it. And now I will not take much of your time. And I wish you all very best and a very, very best wishes for this very good webinar. Thanks. Thank you very much.
Thank you, ma'am. But it was it was a real few things to be picked up, that never be afraid of a little bit more harm, and we have to be very meticulous, and we can take before, like we take a early decision for the hysterectomy. Likewise, a simple thing what we can have, like Dr. Pally says about aortic compression. It is same thing almost what you say, that this is something a new thing, and that is the being with the gurus, what we say कि जब गुरु के पास बैठते हैं तो आपको अपने आप ही कुछ मोती और मिलते हैं, हीरे जवाहरात, और this is something we have picked up. Thank you, ma'am, for always
One
being
thing,
with us.
Sadhna, I will like to add here that
Yes.
I don't go much for aortic compression. Rather, the flabby uterus which is bleeding, I just roll it. I
Oh.
just roll it and compress it on the pubic symphysis. This is like
Yes.
just stopping the bleeding, and then I go for internal lytic ligation because I have been trained like that. So, and once you have ligated, it is all bloodless. Now you unroll it, whether you go for Lynch operation or not, D-Lynch, V-Lynch, whatever, or it is a compression suture. So they all matter. But I think all obstetricians should know how to go for internal lytic ligation. Thank you.
That's why, ma'am, we are having all these series, and we are having a great association with Shashi and Dr. Manju Puri, because we really want to spread this skill. That is that turning challenge into the expertise opportunity. So thank you very much. And now we have our president secretaries of Greater Noida, Moradabad, Bareilly, Bulandshahr and Shahjahanpur societies are with us. So it is a real thanks to Dr. Sadhna Jaiswal, Dr. Samta Gupta from Greater Noida, Dr. Aradhana Singh, Dr. Shweta Mathur from Noida Society, Dr. Manisha Jain, Dr. Dipali Verma from Moradabad, Dr. Nadila Sharma, Dr. Gayatri Singh from Bareilly, Dr. Pravila Mittal, Dr. Indu Singh from Bulandshahr, and Dr. Deepa Saxena, Dr. Monica Gupta from Shahjahanpur Society, because it is only your cooperation and all coming forward, so that we have all faculties representation from all societies, and we are together in saving mothers everywhere. So thank you all the president and secretary, and it is a real pleasure to have Richa as a guest of honor, though Richa actually I have been knowing her since childhood. Her father was a friend of my father, so it is so good to see. And sometime when Richa had just joined as a head of the department, and I visited my own medical college, SN Medical College, and then we come to know that really we have become very senior, because Richa, who I've been following since childhood, now she is gracing the head of the department post in SN Medical College, Agra. Always a brilliant student she has been, and now she is professor and HOD, SN Medical College, Agra. Best Teacher Award by students of SN Medical College, Agra. Past Secretary, Agra Upstani Society. Vice President, Indian Binopol Society. Organizing Secretary, Midterm UPCOG 2018. Joint Secretary. In every program and in every association of Agra, Richa is one of the very important pillar. She has been awarded Kamini Rao Yuva Oration at AICOG 2010 Guwahati, Padma Shri Usha Sharma Oration at 2018, and she has been recipient of Foxy Korea Research Award. So actually we share a lot of legacy, alma mater, place, and the academic prizes, and Karan Gupta Award, Jagdishwar Mishra Award, Jamna Prasad Award in National AICOG, and a very ardent academician. And Richa, we really wish to have, because I was just, it was something which is really happening, the revolution in the public health facilities. And it was just 1 or 2 months ago when I was in medical college, we could see a lot of changes what is happening, and there are the actually true revolutions are happening, because we have the political will and we have the administrative will, and along with the clinician expertise like Dr. Richa. So Richa, thank you very much for being with us, and we wish to listen to you for this very, very important subject.
It's been 25 years now since I'm in this department at Agra. And over the years, since my residency years, there has been so much evolution in the management of PPH. In those days, we had syntocinon, methergin, prostidine. And now the armamentarium of drugs has increased to carbetocin and misoprostol. And misoprostol, we all know, not only treatment, but has a very important role in the prevention also. Especially now when we are using it before cesarean section, just after spinal anesthesia, if we keep a misoprostol tablet per rectally, that has also, we have done a thesis also, and that is very effective in reducing the blood loss and early separation of placenta. Then coming to the surgical skills. The surgical skills have definitely advanced in the last 2 decades, and because of more workshops, conferences, webinars, awareness, and internal iliac artery ligation, the hemostatic sutures, they have come up to be very helpful in preventing. Initially, a lot of obstetric hysterectomies were done, but in the last 15 to 20 years, because of the use of these sutures and in stepwise devascularization, we are able to prevent many hysterectomies. Many patients can be, the PPH can be managed in the labor room itself by balloon tamponade. So this is the evolution which has occurred in the management of PPH over the years, because this was a long-standing menace or dreaded menace in our branch. And the efforts by gynecologists like Sadhna ma'am has led to awareness, and many more other gynecologists have led to this awareness and increase in the skills. One thing which I would like to add is that when we have a high-risk case, like a case of antepartum hemorrhage, severe preeclampsia, we are obstructed labor, we are psychologically prepared. We have our packed cell and fresh frozen plasma ready. The patient is also counseled, the attendants are counseled, and we are ready for postpartum hemorrhage. Problem occurs when the primary gravidas without any reason pass into PPH, as occurs with all of us. Their counseling of the attendants becomes difficult, because there was no pre-existing associated high-risk factor. We have not counseled them for PPH. So that is still a challenge. And to counsel them, because they think what has happened suddenly, that the patient has started pouring and now you require 2 to 3 units of blood and you are asking for FFP, something has gone wrong. So that mental status of population of our public needs more awareness that PPH can occur in normal patients also. We have advanced ourselves in managing PPH. We are doing very well in high-risk pregnancies, where initially, like in patients with obstructed labor and with severe preeclampsia, PPH was very common in grand multiparas. Many a times obstetric hysterectomy was needed to be performed to save the life. Now we are able to save the uterus. But public awareness regarding PPH is a milestone which is yet to be achieved, that this can occur in any patient. The government has gone miles ahead. It is organizing so many national training programs for the doctors posted in CHC and PHC. We have RRTC program, we have EMOC, CEMOC also, for the training of these doctors for management of obstetric emergencies and especially PPH. They are providing NASG garments also at CHCs. The drugs are being provided. So we are able to manage PPH, or at least they are able to refer the patients in a better state so that they can be saved. Then now we have ICU facilities also, and since last 2 decades, ICU facility has gone up, so we are able to manage them post-operatively also better. So we have gone far ahead in managing PPH, but it still remains a dread, especially when it occurs unexpectedly. And that is the message which I would like to conclude. that the awareness program, and ma'am was especially very active in high risk pregnancies and PPH during her vice presidential, and she was also of Safe Motherhood Committee. She was very active since many years, even before her presidential campaign. We are really thankful to teachers like ma'am and others who have boosted up, especially the gynecologists who are in private setup, because we are in a government setup. So we have a team backup also, and sort of umbrella protection of government setup also. But in private setups, it is really, they have trained the clinicians so well in management of PPH by these workshops and webinars.
Thank you, Richa. Thank you. It was something really a good journey, and like you have like all things, what are the challenges and the like positivity about the government setup. And there is no way, like in India, actually, we are fortunate to have a very robust now public health system and a parallel private healthcare system. So if we really coordinate and complement well with the mutual respect and the mutual referral, we can really do something great for our country. Thank you, Richa, for being with us. And Babita, you go ahead with the scientific.
So without much ado, let's quickly move towards the scientific session. Our first talk is by none other than Dr. Sadhana Gupta, and she'll be talking on prediction, prevention, and management of resuscitation and medical management in PPH. And for this session, let me invite our esteemed chairpersons, Dr. Rakhi Singh. Madam is chairperson of Endocrinology Committee, FOXY, vice chairperson of UP chapter, ISAR, and she's peer reviewer of Journal of Obstetrics of India. She is invited faculty for 350 national and international conferences and is recipient of FOXY DC Datta Award for publication, Hepatitis B in Women, and the CS Dawn Award at the 65th AICUG. She got the first prize for it. She has written chapters in books, FOXY Focus, Jeffcott Gynecology, Fibroids Management, ISAR Express, Dilemmas in IUI, and is recipient of Wonder Foxian Award, Dhira Award, and ICOG Appreciation Award. A very warm welcome to you, ma'am. Then we have Dr. Sadhana Jaiswal. Madam is President, Greater Noida Obs and Gynae Society. Kindly change the CV. Sahiti? Yes. Madam is at present the President of Greater Noida Obs and Gynae Society, and she's Senior Consultant, Apollo Cradle and Spectra, with 37 years of experience. A very warm welcome to you, ma'am. Then we have with us Dr. Kanchan Prasad. She's Professor TMMC in RC Muradabad, Fellow in Reproductive Medicine and Diploma in ART. She's North Zone Coordinator, FOXY CRC Committee, recipient of several awards, that is the Champions of FOXY Award, CS John Paper Prize at AICUG Bhubaneswar, Best Paper Prize in FOXY International Women's Health Summit, Best Poster Prize, Paper Prize National ISOPAP. She is past Joint Secretary, Haldwani Obs and Gynae Society, and is reviewer of the Index Journal. A very warm welcome to you. I hand over the session to our chairpersons to invite and introduce the speaker and to conduct the session.
At the outset, I would like to invite Dr. Sadhana Gupta for her talk. Who all doesn't know Sadhana Gupta? She's very well known to all over North India and India, what we know of. And she has got that zeal to work at length for the people, for the public, for the smallest reasons on earth, which become the major reasons. That's why I think she's been doing all these webinars with the basics which are required to be done. Her CV has already been read, so I'm not going to read her CV because it has been already introduced. And I would like to introduce her Dil Se, because she is a person of value who requires everybody's cooperation also. And looking forward to see you, ma'am, at the highest level. And waiting for your talk on resuscitation and medical management in PPH. The context setting has already been done by Dr. Richa and Dr. Anuradha Khanna, madam. none other than the two legends.
Thank
Over
you,
to you.
Rakhi. Thank you, Rakhi. Actually, really, we know each other since so many years that we are a real part of family. And my regards to Sadhna ji and loving regards to Kanchan. I will be like setting the ball rolling, and this is something because the first line management, that is the in first are what we do, and what we do in our day-to-day antenatal care practices. This is the most important thing which can actually prevent either PPH or severity of PPH. So I have been really, really fortunate to have all these association where in this journey we have found a wonderful people. And just yesterday I was at Lucknow and having such a all things, the scientific discourse, the personal wishes, good wishes, and the association, that is the thing what we actually gain when we work for our professional bodies selflessly around the world and around the country. At the moment, my workplace have been since 30 years. I'm in the Gorakhpur. I was in the belong to Agra. My alma mater was in Agra Medical College. And the both, what is it is a Krishna or it is Buddha who says always be peaceful at the core of your heart. So PPH, we know and we reiterate, every talk starts with this, that it is contributing to around 30% of all maternal death. And in our setting, in the what we say India, South Asia, it may be around 45 to 60%. But actually statistics does not attract us because it is somewhere, it is a something number. But when we take the OB-GYN as a branch, what is there in very, very earthy manner, that is we are bound to encounter PPH in around 2 to 10% of all deliveries, out of which 1 by 1,000 can be massive, life-threatening. When the patient had the severe PPH, a long-term severe morbidity, anemia, Sherman, secondary infertility, a lot of social issue like abandonment because of any hysterectomy done or the secondary infertility, all things come together. And it is a lifetime scar for obstetrician and our team also if we lose any patient, any young life due to postpartum hemorrhage. So in India, when we are really going to be the third largest economy of the world, actually the hemorrhage is causing around 35 to 56% of our maternal mortality. What is PPH management? Actually, something when there is any difficult situation, any challenges, it brings out whatever you have done all over the life, be it any lactoral process or be it handling the postpartum hemorrhage. What you have been investing in day to day, in moment to moment, that tests your management efficacy. It tests your functioning of health system, how input you have given to that skill of how ready is your team, because it is coming to us suddenly, unexpectedly. And we can lose the patient in a very short span of 1 to 2 hours. And we have to be ready for all the new challenges. Like in India, we have everything in like a ample. So we are having still the issue of anemia, nutritional deficiency. And FHS5 says that every second woman, actually incidence of anemia has increased, and it is going to increase the PPH related morbidity as well. Still, we have a little bit delays also, but we have all the new challenges, pregnancy with IVF, with comorbidities, with myoma, and with the coagulopathy, where again, there is a skill gap, knowledge gap also, and a very increasing incidence of the placenta accreta spectrum. So all these the programs, workshop, be it a physical, be it a virtual, what we want that you have every person who attend these workshops, they have a clear roadmap that what to do next and what to do next and how to utilize the every resource setting. Dr. Samartha Ram is with us. Like a simple measure can give you a really like a a very rapid improvement in the patient situation, so that there should be no chaos, there should be no confusion. You must have a very clear cause analysis, because we really don't want to have that PPH related criticality and mortality, which is a real something very depressing. Echoes are like, we don't want to talk about it, and we are losing a lot of medical, legal, and the social issue, the social and all things are there. So we have to be ready. We cannot, it is like when we are obstetrician, we have to give the obstetrical care service. There is no way that we can err away from it, but we have to be ready. So this thing which we want, that when the patient with PPH comes to us, there should be no further delay at the third level, that is the tertiary level. We must have a something blue code sort of thing. Whenever a patient have PPH, or suddenly a patient PPH is referred to us, everyone should be in alarm and everybody should be in the place, because now we have the political will, we have NRHM, we have the community worker, we have a road ambulance, we have water ambulance. Just a few months ago, I was in Jorhat and I found that there was a water ambulance coming from Jorhat to Mudgil. So political will is there, and we have to be ready with our armamentarium. Prevention is the thing. Prevention is a modern medicine. Prevention is a futuristic medicine. So what we do to prevent, it does not start from labor room. It starts from our day-to-day antenatal care clinics and the OPD. Take very good history of all high risk factors. Few are important because we really miss those. That is the treatment with anticoagulant, any pre-existing bleeding disorder. So any adolescent which is having heavy menstrual bleeding since beginning, it is time that we take a pause and consider that she might be having no other problem. Of course, previous cesarean section and the location of placenta previa and preeclampsia and multipetal pregnancy. Important thing that as a August OBG expert clinician, you are noting everything, but it is in your mind, but it should, the knowledge should be turned into the action, and only then in this universe, only our action matters. So we have to not only identify flash at a particular place at antenatal card, maybe by the red pen or something, counsel family that she can have the PPH, and all over the country, all labor room staff should be sensitized to this, that if you have seen that in record, it is any risk factor for PPH, we should be ready with all armamentarium. Active management of third stage of the labor is the thing that over the 25 years, I have done a lot of work on this, and the changing arms of the active management of third stage of the labor. What are the advantages? It is like a vaccine against postpartum hemorrhage. It reduces risk of PPH, reduce severe PPH, need of blood transfusion, anemia, uterotonic medication, and with now late clamping of the cord, it is advantageous for the baby also. So oxytocin 10 unit, either intramuscular or IV in the fluid, is the thing which is to be given to every woman who is delivering, because any person can give without any hesitation, because we have absolutely no contraindication for use of oxytocin, and it has no effect on the maternal vitals almost. Misoprostol we are using a lot, but just I wish to say that it is a second choice for drug. So if it is not, oxytocin is not available, or any injectable facility is not available, like in community setting, very remote primary health center, then we can give the misoprostol. But for active management, it should not be given at the rectally, it should be given either orally or the sublingually. So all professional body, FOXI, FIGO, WHO, it is all that every woman should receive the active management of third stage of labor. And carbetocin has come a long way, it has been over. And why carbetocin is a very important drug, especially for us, because we have the room stable carbetocin, and it is a long-acting oxytocin with a very strong affinity to oxytocin receptor, and we need only single dose for the carbetocin. So it is not to be continued. So these are the few beauty of this drug. After a champion trial in which India was a strong contributory, it has been recommended as one of the very good choice, and maybe the first line choice for the active management of third stage of labor, be it in cesarean or vaginal. And I wish to emphasize that every time we have a question like we are using in cesarean, not in vaginal delivery, actually it is the same efficacy. Just because of the cost reason and not availability at the public health, we are not like using it for the vaginal delivery in many settings, but it is not that costly drug also. Another beauty beside being having the room stable option and a strong affinity, important thing is that it eliminates the requirement for infusion after the initial dose. And when we are having around 10 to 15% of hypertensive disorder of pregnancy and the 50 to 60% anemia, it is a very, very good advantage because the patient is not overloaded with the fluid and the oxytocin. Important thing that yes, AMTSL for everybody, but all these drugs should be available at the bedside of the laboring woman. That is very important. We must have the refrigerator close to labor room. We must have the refrigerator close to our cesarean section, operation theater. And every person in the team must be knowing that when the patient is delivering, oxytocin, carbetocin, and misoprostol should be there so that we can choose the best. And oxytocin and the long-acting oxytocin, that is carbetocin, is the drug which has to be given, which is the most important arm of active management of third stage of the labor. Controlled contraction is one of the arm, but just I wish to emphasize that there is a bar that when a person is experienced in doing that, only then you should do it. Otherwise, wrongly done controlled contraction in a relaxed uterus in a wrong way, it can itself cause the postpartum hemorrhage or the inversion. With this, having said that the PPH is unpredictable, you suddenly find what Richa says, that it is very difficult that suddenly a patient, low risk patient have the bleeding, and you have to be prepared because we know that it is going to happen in 2 to 10% of the laboring women. Why do the mother become critical or die? Because there is a delay in correction of hypovolemia or delay in control of bleeding. And that first hour, which is a golden hour, is the time where we can make a change, difference between life and death and the criticality and the mild morbidity. So this is important, and never shift the patient after delivery to the postnatal routine ward. It must be a policy that they should be there for around 1 to 2 hours, where the paramedicals, resident doctors look for bleeding PV, tone and height of uterus, pulse, BP vitals, and the oxygen saturation. We can have primary and secondary PPH, but important thing when you are being called for that, taking the for the postpartum hemorrhage, first make a very, very quick analysis, 360-degree view of whole situation, because cause analysis must be in our mind while we are resuscitating and doing the initial management. Tone, tissue, trauma, thrombin, these are the classical teaching. Important thing is that our cause analysis must be very, very robust and clear. What were the precipitating factor? It was induced labor, it was preterm labor, what drug she has been taken, whether ultrasound show any fibroid or the placental location, any possibility of placenta accreta. So the smartness of clinician is in the thought process. It is not a burdening ourselves with a lot of knowledge and information, but that knowledge should be turned into wisdom, because we know the priorities, that the cause of PPH in this patient is this, and we have to focus on to this. So few patients very, very respond to the simple treatment, and a few patients really require shifting to operation theater. So cause analysis must be very, very smart, very, very important, and we can have more than 1 or 2 or 3 causes, because you are using a lot of drugs today, aspirin, heparin, a lot of a tocolytic, because we are giving Maxel, we are giving nifedipine in the preeclampsia, and all can cause atony and add it to the prematurity. So we have to be very, very important, very, very quick analysis for the cause analysis. Why we still have a delay? The thing which is so evident that the patient is bleeding, still we lose 1 hour and 1.5 hours to taking that this patient is having really moderate to severe PPH, because nature has been kind that the pregnant woman is having hypervolemia, so there is no sudden change into the pulse and blood pressure. And if we rely much, yes, BP is okay, 110, 100 or 98, 95, it's okay. And we lose that opportunity of golden hour. A good visible estimation, what we have been doing, all physical thing that we are putting this rat Congo, the ink and the cotton, and we ask question, what is the estimation of blood loss? We have come a long way, and we have Chhattisgarh like a bag for estimation, our own Devdas bag. Few important things which you have a clear instruction to your staff. If the patient have 5 soap normal size bed, 1 soap big sanitary napkin, continuous trickle of bed, or she is having a nausea, she is suddenly vomiting, she appears confused, this is the time that the senior obstetrician must come into the picture. Blue code always to be there, and whom to call? Our anesthetist friend who is morally boosting, who is smart, senior nurses, obstetrician colleague, ward boys and guys, theater staff, and the blood bank person. So you have to be ready, like when you are in peaceful, you have to be ready with a confidence boosting and the like a friends who are expert and who are ready to handle and come at any time of the day or the night. So this is something non-technical issue, but you have to invest in developing friendship with the very wise and the people who are dedicated, who does not care for sleep or the summers or the day or the night. So we have to have that army team always with us. What is after diagnosis? The second thing is what is the amount of the postpartum hemorrhage, because that sets the stage how vigorous our resuscitation should be there. So these are the few indicator: pulse, blood pressure, postural hypotension, capillary refill, and the urinary output, which gives you like within a very, very few seconds that what amount of hemorrhage patient is having, what is the pulse rate, blood pressure is doing, or if you do the capillary refill, it is a delayed or the prompt, and the shock index, which is a very simple measure, but you have to have the cardiac monitor in your labor room and always in cesarean section OT. I will more emphasize on the labor room, because only then the patient, like our all staff, will be confident that yes, we can measure the shock index, and if it is less than 1, it's you have a breathing space, but if it has crossed the 1, that is heart rate is higher than the blood pressure, then you have to be very, very vigorous. Golden rule of 30, we all know. So all things depend upon pulse, BP, respiratory rate, and the urinary output, and we have to be ready with all oxygen cylinder, emergency trays, PPH, all the things, and all the thing, like always I will say the oxygen cylinder key must be like आप गॉस पीस से उसको टांग के रख दीजिए, so that आपके पास सिलेंडर है सब भरे हुए हैं लेकिन आपको की नहीं मिल रहा, उसके लिए कभी गार्ड आ रहा है. So these are the few things which are non-technical, but they are very, very important. So if the blood loss is around 500, you have to start with the basic resuscitation and always look that ongoing hemorrhage is not or not, because it is a very common mistake that initially we think it is a mild PPH. Yes, we give the normal saline, everything, it will okay. But the ongoing hemorrhage, you must be very, very careful, and always 2 IV line, that is very important. If it is around 1000 ml with all rule of 30 shock index, then you have to be ready with full protocol of measure, and never scold your resident or nurse that why you called me because patient is not breathing, because next time they must be afraid of it. Airway, breathing, circulation, give oxygen irrespective of oxygen saturation, always green or the gray cannula, no pink cannula, IV cannula in the labor room. Keep patient flat, keep patient warm, see that AC is not like where or the 18-degree temperature something. Give oxytocin infusion. If you have not used carbetocin, you can even give it air catheterized, and always the crystalloids are our core methodology for the IV fluid resuscitation. Aortic compression, sometime in a sudden massive hemorrhage, patient is grossly unstable. You can use it by shifting the uterus to the postpartum uterus and giving pressure on the aorta. And you have to resuscitate, investigate, monitor, communicate, and record keeping. There must be some person to tell all the things, what is happening and what hard effort you are doing, because that is very, very important. When you are putting the first IV line or the second IV line, take the blood for blood group cross matching, take the blood for the all investigation and all the coagulation profile. So you must have around 3 plain vial, 2 citrated and 2 EDT vial, and they must be in our PPH box along with the blood transfusion requisite form. So many times everything is there, but blood transfusion requisite form we are not getting, and we are having around 5 minutes wasted in that. So this is few important things. PPH care bundle, we know e-motive bundle, which is a bundle is a like a the combination of the thing which are effective clinically, and this is arms of our e-motive or the PPH bundle, that is uterotonic drug, crystalloid, tranexamic acid, and uterine massage. So calling of the help and I will say the fluid resuscitation. So 2 things are important. Crystalloid, ringer lactate, and the normal saline is fluid of choice. Amount, it should be the 3 times what you are estimating the amount of fluid. And why the crystalloid and normal saline and not hemaxil? Because the ringer lactate, normal saline, they rapidly pass from the intracellular to the extracellular space. It does not cause the pulmonary edema, and it is important, it does not interfere with any coagulation profile. So the ringer lactate, normal saline is fluid of choice, 3 times what you have estimating. If you have given around 2 liters of crystalloid and the blood component is not there with you, in between you can give the colloid up to 1500 ml. So these are the few important things. Now, at this time, when you are having what I say cause analysis is sharply running into your mind. So ask right question. Placenta has delivered. If not, again see that it is complete or not. There must be a strict protocol that you don't throw away the placenta before 2 hours. Placenta bleeding start after delivery, likelihood of the genital trauma, better always explore early. And if placenta not delivered, always mobilize team for MRP. It might be there by the time anesthetist come, by the time you took the patient, placenta may be expelled. But you have to mobilize team, because 1 in 20 or 30 times the patient will be in shock before that, if you take around half an hour to mobilize your team. If any suspicion of past disorder, never go for MRP, and you have to review the ultrasound and obstetrical history. Catheterization, very important. Amount of urine, hematuria, which tells you about the possibility of trauma. Simple circular movement of the fundal massage, evacuation of blood clot from the vagina. These are very, very important steps. Medical management, now we are fortunate, we are having a lot of drugs. Important thing is that we must optimize the use of these drugs. Exclude contraindication and optimize the dosage of the thing, so that you can give around 4 ampules of the methyl ergometrin, around 6 to 7 ampules of the prostaglandin, and they must be stored into the good temperature, that is in the door of fridge, and available in a 1 box. So these are very, very important things. If one drug is not effective, if the syntocinon is not effective, methylgene might work. Methylgene not effective, prostaglandin might work. It is not effective, then the misoprostol might work, because the oxytocin receptor are different, and any drug can be helpful to you. Especially if you have given oxytocin for induction, that patient might not respond to oxytocin, but it will respond to methyl ergometrin. So this is very, very important, that don't take that you are using only 1 drug and you are using only 1 or 2 ampule. Important thing is that you optimize the all drug, and they should be available with us. That is the important. Just a quick recap about the contraindications. So methyl ergometrin, moderate to severe anemia, hypertensive disorder, valvular heart disease, prostaglandin, that is the bronchial asthma and the glaucoma. So these are very uncommon, and misoprostol also you can give almost in every patient. Tranexamic acid, after women trial, it has come to our rescue. So prophylactically, you can give in all high risk of the patient who can have PPH. And if the patient is having PPH, you give like within 30 minutes of diagnosis and repeat after 1 hour. But note, after 3 hours of the diagnosis of PPH, it is not going to work. So tranexamic acid is the drug which is very, very important substantial factor on the severity of the PPH and in the management of PPH. Just a word of caution that tranexamic acid ampoule resemble bupivacaine, and there have been reports and the paper itself that it has been inadvertently given for regional anesthesia. It is the paper from anesthesia from the developed world, and in our own National Medical Council, we have few cases about it where patient lost life or became critical. So we must have a one magnifying glass also in our routine, because many injections actually resemble, and sometimes in hurry, the human errors can be there. When to think of blood transfusion? If moderate to severe PPH, hemoglobin, if the HemoQ we must have with us so that we can immediately have the quick glance on the hemoglobin. If hemoglobin is less than 7 grams, this is time that we organize for blood transfusion. If there has been the precedent, any incidence of obstacle which can cause coagulopathy like abruptio, HELLP syndrome, intrauterine fetal death, then we have to be very careful about the coagulopathy and the availability of the fresh frozen plasma on the cryoprecipitate. We now talk of a thermoelastography and many things, but important thing, the simple bleeding time, clotting time, clot observation test, which we used to do around like years ago, and I still use. If there is a like severe hemorrhage patient is having, especially when there is a no clot in the bleeding, patient is only bleeding like a tap or something. This is the simple test at the point of care. Within 10 minutes, you come to know that it can be coagulopathy, and a very good paper by Dr. Nalini Mishra from our own country that this point of care test correlates so well with the fibrinogen level. Massive transfusion protocol, like important to just say one thing, that massive transfusion protocol start when you have given 3 to 4 units of the PRBC. After that, there is a chance because of the heavy IV fluid resuscitation, and with the only PRBC, we can have the consumptive like a dilutional coagulopathy, and then we start, that is 1:1:1 or 2:1:1. So important that after around 3 to 4 units of PRBC, patient is having ongoing bleeding, then we should always consider that 1:1:1 and always correlate with the all thrombin time and the coagulation profile. We want to achieve hemoglobin more than 8 grams, platelet count more than 75,000, the all target, because we don't want the patient to be critical. We want the patient so that she is having safe. PPH trays, PPH trolleys, we have done, Dr. Sheila Mane, we have done a lot of work that the all people have this thing, and we must know that in these PPH trays now the SR cannula should also be there. This is very, very important that they should be with us. Always record vital parameter, event, what fluid have been given, what effort you have given, and communication. Howsoever difficult situation, you have to be cool and composed. Join Manita so that all your nursing staff is confident enough to deal with the diagnosis and the identification and the first line resuscitation. Treat the cause, what we have said, we have to say. We are going to have it something like it. So all like Dr. Shashi and Dr. Dr. Samartha is going to tell. Important thing, learn the art of bimanual uterine contraction. Always I say SR cannula, we are going to propagate in our country in a big way. Important one decision which I say, that when to explore, when to take decision that we want to shift to operation theater. Sometimes out of our own hesitation, sometimes because what the patient will say, you have to take to, we are really scared to say. So important thing is that when the patient is having what we say, having a like a moderate to severe hemorrhage, she is having unstable vital, you are not able to palpate uterus, this is the time that you take the patient to OT boldly. Whenever there is a chance of trauma, good under OT setup, good anesthesia, good visualization, and our own innovative like transvaginal uterine clamp, our own Dr. V.P. Pelly as a presidential candidate. Really, this is something that we honor our own innovator. We honor our own experience, and that will show the way to the world. This is very, very important. Our own Chhattisgarh balloon tip and low cost at the point of care you can give, and always ready with the protocol. MRP, I will just say that difficult part about MRP decision to undertake it, what I and donor say. Beware of coagulopathy. We are having a lot of dengue, Apla syndrome, drug-induced thrombocytopenia. Here is the thing, we have to be very, very alert about all the issue and taking the right. And what I say, that time to think for laparoscopy. Sometimes you don't have to do anything. You have to take the patient to the operation theater. Flabby legs, pouring blood. It is no clotting, nothing. You are not able to suture. You have tried cervical, you are not finding any apex. You are finding that the uterus may be ruptured. So this is the time that you cannot waste your time. You have to be very, very quick and always take. We are having a video session where we will learn all these skills. So we have to save lives and we have to be setting protocol for every situation and take bold decision like a leader. It is not always that you take goody decision, you take delayed decision. You have to be leader of your team and always be with them, never scold them, never take out their confidence. And when any surgery is needed, do it, because life-saving surgeries, you can do it even sometime without consent. It will actually save you in potential medico-legal issue. So if you can fill the unforgiving minute with 60-second worth of distance, run. Yes, it is postpartum hemorrhage. With this, I seek everyone's full-hearted support for my upcoming election. It is from 1st August to 10th August. I have been involved today with your own societies. I have been evolved out of you. I have been with you together since 30 years. And I hope and believe that we can make a change by sharing a respectful inclusion of all expertise and experience from all parts of the country. Thank you very much once again for active listening. And
thanks, Dr. Sadhna, for a very, very informative and exhaustive talk. You have covered every aspect, right from filling the blood requisition form, key to open the cylinder, keeping the magnifying glass, every single thing you have covered. And I'm sure that with our collective efforts and the training of the staff nurses, definitely we will be able to control the maternal mortality rate. And I would also like to emphasize that Dr. Anuradha and Dr. Richa said, we need to keep the hemoglobin of the patient from the very first antenatal visit. It should be at least 11 gram%. And also identifying the high-risk cases. I mean, it is such a vast topic, but we have covered it so beautifully. Thank you. Thank you so much. And we are all with you, madam. We are all with you. Definitely, we are going to make you the president of our Fox Society. Yes. Thank you, madam.
Yes.
Thank you so much, ma'am. You have explained everything so brilliantly, especially few points which needs to be highlighted. You have highlighted so well. So about the cannula, always for green or gray orange cannula, not pink cannula, because the amount of fluid that is going is 8 to 16 times more than the pink one. And always use that first golden hour, because even if we control the bleeding and that golden hour is not utilized to resuscitate aggressively, patient will fall into that deadly triad of hypothermia and coagulopathy and lactic acidosis. Then patient doesn't come out, even if we are able to stop the bleeding. So now it is called a lethal diamond, that we are including hypocalcemia also. And of course, we have to judge the blood loss by shock index and rule of 30, because visual estimation many times may be wrong. So Sadhna ma'am has highlighted everything so well, and we all know PPH is very unpredictable and we need to be alert and a team management. So thank you so much, ma'am, for explaining it so well, and we wish you all the best, ma'am. All the best. You are so suitable candidate, and best of luck, ma'am, for your future endeavors. Thank you, ma'am.
thank you, Rakesh, Sadhna, and Kanchan, for your precious wishes. Am I audible?
Yes, you're very much audible.
Yes. So thank you, and thank you for appreciation. And what we say, it is the technicality and it is a non-technical issue. It is all your thing which we have to get ready. And thank you. So Babita, you can go ahead with the second.
Yes, so thank you, speaker and chairperson, for conducting this session so very smoothly. Now we move towards our panel discussion. We have atypical case situations in PPH. Our moderators for this panel are Dr. Jyotsna Suri ma'am. Madam is Professor, Unit Head in Charge, Critical Care Ops, VMMC and Safdarjung College Hospital, Delhi. She is Vice President AOG, National Corresponding Editor Jogi, Chairperson Safe Motherhood Committee AOGD 1921, and Chairperson Multidisciplinary Committee AOGD 2016 to 18. She has edited and co-authored the book Practical Approach to Critical Care in Ops, delivered more than 200 guest lectures in international, national, and state conferences, and conducted several critical care obstetric workshops, and awarded the WHO Fellowship in Reproductive Endocrinology in 2019. She has been awarded the C.S. Dawn Prize for Best Paper in AICOG and is recipient of APJ Appreciation Award of Academician of the Year Award conferred by DGF in 2021. She is Principal Investigator, Action 3, WHO Trial, and ICMR project on screening for GDM. A very warm welcome to you, ma'am. Then we have with us Dr. Shiva Marwa. She is Associate Professor, Department of Ops and Gynae, VMMC and Safdarjung Hospital, New Delhi. She is Co-Critical Care Obstetrics Team Member and DQM Training Division of Quality Cell Team. She is Member Labor Room Quality Care Team of Lakshya at VMCC Safdarjung. Course Faculty for Critical Care Course in Ops by DGFS and BMMC 2021 onwards. She's co-editor AOGT Bulletin. She's Faculty Coordinator for BMMC in Safdarjung Hospital. She's Chairperson Menstrual Disorders Committee, SMDHM. She's COVID-19 Nodal Officer, past Assistant Editor AOGAD. She is recipient of several awards, be it the APJ Champion of Obstetric, numerous awards for national and regional paper presentation, and the C.S. Dawn Prize, Award of Excellence for Outstanding Public Health Work done during COVID-19. A very warm welcome to you, Dr. Shiva. We have as expert panelist, Dr. Chitra. She's Senior Consultant, Head of the Department of Ops and Gynae, Apollo Hospitals, Noida. She has been practicing since 37 years, and her areas of interest being high-risk ops and operative endoscopic surgeries. She's founder of Noida Ops and Gynae Society and President of Noida Ops and Gynae Society. She has keen interest in teaching. A very warm welcome to you. Our panelists for today are Dr. Punita Alpana Agarwal. She is FOXY honored with certificate of proud member of FOXY and has written several e-books on pregnancy, breastfeeding, contraception. Her books were published on Amazon.com. She is based in Bareilly. A very warm welcome to you, ma'am. We have Dr. Anubha Agarwal. He is Consultant Ops and Gynae in Care Multi-Speciality Hospital, Bareilly, and is doing private practice for more than 15 years, and an area of interest being high-risk obstetrics. A warm welcome to you. We have Dr. Pragati Agarwal. He is past Treasurer, Bareilly Ops and Gynae Society, and Treasurer of Midterm UPCOG 2019. She is past Clinical Secretary, Bareilly Ops and Gynae, owner Pragati Hospital, and is awarded FICOG in 2022. A very warm welcome to you. We have Dr. Deepa Saxena. She's Senior Consultant Proprietor, Bridgedeep Hospital, Shahjahanpur. She is conducted the endoscopy workshop in 2001 in Shahjahanpur and presented paper at National Conference of FOXY in 2004. A very warm welcome to you. Then we have Dr. Okay, so we are done with it. Dr. Punita Agarwal, you can display a CV, I think. We have Dr. Punita Agarwal. Yes, she's Consultant of Ops and Gynae, Nipun Hospital, Shahjahanpur, and practicing for more than 20 years. Her area of interest being high-risk pregnancy and minimal invasive procedures. So very warm welcome to our moderators and panelists. We look forward to a very, very interesting session.
Ma'am, can I start my screen sharing?
Yes. So good evening to all. Thank you, Dr. Babita, for the kind introduction. And we are very privileged to have, Shiva, you can share the screen, please, to have our expert, Dr. Chitra Sethia, and all our esteemed panelists with us this evening for this webinar. And we'll be talking about the challenging cases in PPH. So, yeah. So to start with, I just wanted to put this slide here to show that even though we have achieved a lot today in terms of, reducing the maternal mortality rate, but still we, the pockets where the concern is there is these particular pockets where you can see the orange shade and the dark orange and the light orange and the mustard shade. So these are the states in our country where the maternal mortality rate is still unacceptably high. Next slide, please, Shiva. And of all the causes of maternal mortality, we can see that 47% are still contributed by hemorrhage, of which PPH is the main contributor. Next, please. So in our own critical care unit also, we have got, the majority of the admissions are due to the hemorrhage, which are most of them, more than 80 to 90% of them are referred cases. Next, please. So coming to what is the definition of PPH has already been done by Dr. Sadhna very nicely. We have had the overview of PPH from her just now. So we just want to highlight in this panel that it is not just the classical definition which talks about the amount of the blood loss, but the very important thing is that what does, the signs and symptoms which are so important, leading to the hemodynamic instability like tachycardia, hypotension, oliguria. So these are very important to pick up early so that we don't have a case with complications. And yes, next please. Yes. So there is the classification into minor and major PPH, which is further divided into the moderate and severe. And what is again, very important that a pregnant woman, because of the physiological changes, she has got an increase in the blood volume. So she may not have a life-threatening condition until she loses more than 40% of the total blood volume. So it's very important that she has a capacity to lose blood, and at that stage she will collapse very suddenly without warning. So it's very important, again, I would like to highlight, to take, the early management of PPH actually is very, very important. Next, please, Shiva. Yes. So again, this is one very important paper which was published about the shock index as a predictor for maternal outcome in PPH. And we see that any time the shock index goes above 1, there are poor outcomes. So this again, I put here for everybody to, take the notice that we don't want them to deteriorate, beyond that stage. Next, please. Next. Yeah. So the golden hour of resuscitation, which was already discussed by Dr. Sadhna, as in all critical conditions, the first hour is the most critical. And over here, unfortunately, if we don't do the action, we may lose our patient. So, with this background, we start with the cases. So, yes, thank you, Shiva, for the wonderful slides. So the road to safety, Dr. Shiva has told us, is to manage them timely. And so we come on to this first case. So 22-year-old primary gravida at 35 weeks period of gestation with complaints of yellow discoloration of eyes and urine since last 3 to 4 days and vomiting for 3 days and labor pain since the last 4 hours. So this patient, when she came to us, her BP was on the higher side, respiratory rate was 26, And on examination per abdomen, her uterus was term size irritable, and she was in early labor, 3 centimeter dilated. So when the routine investigations were seen, her hemoglobin was low. It was 8.4. TLC was again on the higher side. Bilirubin was 12.6, and AST, ALT both were high. And KFT was, creatinine was deranged. RBS was 67 milligram %, and coagulation showed the INR of 2.7. Viral markers which were available with her showed that her all the viral markers were negative. Ultrasound was done, which suggested that she had a live intrauterine pregnancy of 34 weeks. Liquor was adequate, and there was mild ascites, along with the comment from the ultrasonologist that there was a bright liver with a mild right pleural effusion. So now with this, case background, what is the provisional diagnosis and the concerns for this patient? Dr. Pragati, we would like you
Yes,
to.
yes.
Yeah.
Ma'am, as in ultrasound, there is shown bright rivers, that is echogenic liver. It shows that it is a fatty liver, and all the parameters like bilirubin is raised, liver enzymes are raised, and this shows that it is the pregnancy with liver disorder, fatty liver, and it may be fatal for both mother and fetus. It is not a mild condition. Even kidney functions are also becoming slightly deranged. This is acute fatty liver of pregnancy.
Yes.
And we should be well prepared for PPH in this case, as the coagulation disorder is also present. PT-INR is 2 point something.
Yes.
That is also raised.
Yes.
So we should be prepared for PPH.
I think you have really put in very well these points, that we have to be prepared for PPH in this case, because already her coagulation is deranged. Second is she's anemic, and she's going into active stage of labor. So we don't have much time to, act. We have to put all the things together and, anticipate a PPH in such a case. So other complications, if we are suspecting this case to be AFLP, by all means, it appears to be one. So the hypoglycemia, DIC, hepatic failure and encephalopathy, ARDS, pulmonary edema, sepsis, MODS, acute pancreatitis, these are all the complications which we may anticipate in a case of AFLP besides the PPH. Yes, so next please. So now in this case, the labor progressed spontaneously, and she delivered a term live male child of 2.5 kg by normal vaginal delivery with the episiotomy. And the active management of third stage of labor was done. Patient had atonic PPH as was anticipated, with a blood loss of around 800 cc. Next, please. Yes. Next, yeah. So the visual assessment of blood loss, how we can do. These are the slides which we have put here for all of you, that visual assessment, is a very important tool. Along with, as we had said, clinical signs and symptoms are very important, but this is the traditional method by which, we have been taught to estimate blood loss, and it is at times highly underestimated if we don't take care of counting all these small gauze pieces and all the blood which has spilled here and there after delivery. Next, please, Shiva. Next, please. Yes. So we have got these special drapes, and your own hospital, what is the gauze size and how much it soaks, all those things. Yeah, we have done it in our labor room. We really recommend everybody should do it in their own workplace so that you get an idea. This is about the different classes of blood loss. Again, what we were saying, that what are the different classes. So only, in the class 3 and 4, the patient really becomes symptomatic, but class 1 and 2 may just go undetected if we are not careful about seeing the shock index and the small, things like her respiratory rate and the pulse pressure. which can be an early sign of increase in the blood loss. The class 2 is the time, we have to catch her before she goes into class 3. Next, please, Shiva. Yes, next. So, Dr. Anubha, what should be the immediate management and what is the bundle approach in PPH and how does it help? So, this case had got a estimated blood loss of 800 ml and now how do we proceed with her?
Good evening, everyone. Actually, Dr. Pragati has told the patient is a case of acute liver failure with a severe liver dysfunction. So 800 ml is already lost and patient is going in atonic PPH. So we will manage the case as a case of true PPH. Already the labor room should be kept ready with the PPH trays. We will call the person for the extra help like expert ICU staff or expert nursing attendant. Will put the 2 IV line and crystalloids like either normal sign or RS should be started. We'll send the blood for grouping cross matching and ask the patient to arrange the blood and fresh frozen plasma or cryoprecipitate. And I will also like to send the blood sample for the fibrinogen level, D-dimer, serum electrolytes also. And till then, Hemaxil can be added till we wait for the blood. And patient's ABC should be properly maintained. Oxygen should be started. We can give the tranexamic acid and this atonic contraction. Atonicity should be managed by compression of the bimanual compression, and we'll put the we will start the oxytocin drip by putting the 4 ampules of the syntocinon or 20 units Synto in normal saline at the rate of 60 drops per minute. And if bleeding is still there, then we will add the methergine 0.2 milligram and we will examine the expelled placenta to see any of the retained bits if left. If it is still atonic, then we will continue the oxytocin drip and we can give prostadine or misoprostol we can put per rectally. But I think in this case, we should avoid carbitocin because patient is in severe liver dysfunction. So next step will be the uterine tamponade. If patient is not responding to the bimanual compression, then we will ready for the this uterine tamponade.
Yes, yes. So you have very nicely elaborated all the steps, very, very well elaborated. Thank you so much. So already because you are anticipating that this has their coagulation dysfunction is there, you have in anticipation arranged even the coagulation factors and the FFP and everything. So very well said. And yes, so this is the pin girl approach, the USAID, that what are the, we normally do our PPH drill. You have very nicely told that the PPH tray should be available in all the labor rooms, and everybody who is conducting a delivery should have a PPH tray with them. And at that time when PPH occurs, we should not panic. So we have, this head end, arm end, and perineum, and what are the roles and who all should be doing what at these 3 ends. Very nicely it divides this. And about the, yes, Shiva, please. So the PPH bundle approach.
I would like to add that the fluid used for any of these drugs should be either ringer lactate or normal saline, not glucose.
Very, very, yeah, very
well
said.
Should know this.
Yes, so our expert has very nicely given her comment, and it is absolutely well taken that it should be the ringer or the normal saline. So we prefer a little bit edges over the ringer, over the normal saline. And yes, that is the drug of choice, the fluid of choice for the initial fluid resuscitation. So we normally can give about 1.5 to 2 liter till our blood products arrive. And in the first response PPH bundle, as this is the latest PIGO bundle care approach. So you have the uterotonic drugs, isotonic crystalloids, and tranexamic acid and uterine massage. We see that all these 4 are part of the bundle. And then if the patient is refractive, then we go to the second line, that is the compressive measures. the temporizing measures like aortic compression and then the bimanual uterine compression and the balloon tamponade and the non-pneumatic anti-shock garment. So this bundle care approach has the advantage that when you use it as a bundle, you don't tend to forget. You remember them and you adhere to those and you practice those elements together. So it always has a better compliance when we are using the bundle care approach. So in this patient, the uterine tone was reassessed. We did the initial management as suggested by Dr. Anubha. But then the patient continued to bleed and the estimated blood loss became 1000 ml. And even though during this time the vitals were stable and the urine output was maintained, but the trickle was very disturbing. Yes, next please. So Dr. Alpana, what would you like to do now further? What about the role of the balloon tamponade?
Good evening, respected dear all. In this case, first, everything is nicely covered by Dr. Anba. Now we look forward. We will exclude any injury or laceration of the cervix or vagina. If it is present, we will treat it. And now we two methods of now new balloon tamponade. Condom balloon tamponade is very nice, and SR suction cannula. Balloon tamponade mein we compress the uterine blood vessels, and SR suction cannula mein we create negative blood volume, negative suction to contact uterus. Both are the opposite but very successful. In uterine balloon tamponade, many ready-made balloon tamponades are available, but condom balloon tamponade is very easy to make and is very cost-effective and very effective. We insert, first we exclude any laceration or injury to cervix or vagina. Then we insert condom or any balloon tamponade in the cervix through 4 toothless ovum forceps holding anterior posterior lip of the cervix and 3 and 9 position mein. Then we slowly safely insert the balloon tamponade in the uterus, and then we inflate with 300 cc to 600 cc normal saline in the balloon and see is it effective. Slow decrease blood vessels, decrease flow of uterine vessel blood. Is it effective? Then we hold it for 6 hours to 24 hours. Then if it is effective, then we see dark blood in the vagina, or there's decrease or no blood in the vagina. Then we deflate it slowly, gradually. First 200 cc first hour. Then we see is blood, no fresh bleeding is coming. Then gradually we deflate it 200 cc per hour. Then we left for the last 30 minutes, deflate it, and we see any fresh bleeding in the vagina. Then we left for 6 hours and observe patient any fresh bleeding. The second is SR suction cannula. In this perforation is present on the SR cannula. We slowly insert cannula in the uterus and attach this to the suction machine and produce 650 millimeter of the vacuum and maintain it for 10 minutes. Then we see and then we shut off the suction machine. By suction, soft cervical tissue are stuck in the perforation of the cannula, cervical portion of the cannula, and it is maintained, steadily maintained. And we see there is no bleeding is coming and left for few hours. It creates negative pressure in the uterus and uterus shrink. These both methods are very good and very effective.
Thank you, Dr. Alpana. You have really elaborated very nicely about the methods. Yes, both these methods are very good and they can control PPH in almost any situation, whether it is due to the atonicity or due to the coagulopathy, along with the other actions which we have to take for coagulopathy, but this can be really life-saving. Okay, next please. Yeah, Dr. Shiva. Yes. So already told about this. So normally we can keep it up to 24 hours. And one more thing, that if we are putting the balloon with the condom catheter and not using the Chhattisgarh balloon, so we must then mark the fundal height, because sometimes the patient may start to have some bleeding inside. So if you are using a simple condom catheter, then keep a watch on the fundal height. So yes, next please. Okay, so despite the uterine tamponade, the patient continued to trickle. So now how should we manage her? And specifically now, Dr. Deepa, we look for the answer from you about management of the coagulopathy. Dr. Deepa, are you there? I think Dr. Deepa is not there. So I would like our expert, Madam, would you give us, Dr. Chitra, some overview about how to manage the coagulopathy in this patient? Ma'am, you are muted, Madam. Yeah.
First of all, we check, you keep continuing doing the bimanual compression and press it so that you have external abdominal aortic compression. And the non-pneumatic anti-shock garment, well, in most hospitals, we don't have that. It is there, okay, as a, thing.
Mainly for transport, actually, it is.
Yeah, it's basically for transport, yes. Because the moment something like this happens in a small nursing home, in a small hospital, we should contact a close by hospital. We tell everybody that close by hospital, go with the patient and ensure that the patient is looked after in a bigger place where they have all the facilities for managing the coagulopathy per se. And call in an anesthetist, inform the blood bank, the hematologist, everybody in a larger center. Don't try and manage coagulopathy in a smaller nursing home. That is very, very important
message I think you have given. We must refer timely and in a safe way. So here the role of these temporizing methods is very important, so that by the time she reaches the tertiary center, she should not be exsanguated. Yes.
And in most of the places, they just have to continue doing the bimanual compression till they reach, because that takes care quite a bit. And there should be two people there, because one person will get tired doing the coagulopathy. So when you're transferring also, there should be two people who are trained to do the bimanual compression.
Right. Yes. And of course, then to treat the DIC, I think it's very important that, this triad of hypoxia, hypothermia, and acidosis, this is the biggest killer in PPH, which also is, the biggest killer in DIC also.
Yes. And in this particular case, the liver is at fault.
Yes.
So that becomes a major issue as far as coagulopathy is concerned.
Yes.
We are not talking only about, PPH. We are talking about acute liver failure also, which is a very important part in coagulopathy.
Yes. So all the conditions, here we have to keep in mind. And at the moment, we are just, wanting to stop the bleeding. So here then the role of the Paxil, the FFP, platelets, cryo, and fibrinogen concentrates. So all these are, very useful in a case of the component therapy. And that's what Madam said, that transfer them early to a tertiary care where you will get these components, because otherwise at district level, you may not get the FFP and the platelets and cryo. So cryo is very invaluable if the patient is, as we saw in our case, she is also in renal failure. If she is not making urine, we can't keep giving her huge amounts of the huge amounts of transfusion of FFP and other things. So cryo in very small volume, we can give her highly, concentrated these factors, and they can be life-saving, and they will not cause, pulmonary edema, and the incidence of TRALI is also much lower with cryoprecipitate. So here, we are using cryoprecipitate in our hospital in such cases. And fibrinogen concentrate is again something which we have found useful. It is very expensive, but can be life-saving. Yes, so the fibrinogen concentrates, these traditionally you just give it for correcting the hypofibrinogemia, but in the liver failure, when we know that there is already a hypofibrinogenemia, it can be very useful in such cases. Yes, Shiva, we can go to the next slide. The factor 7A, she has shown that again, this also in a case where there is no other thing working, it has a limited role because of the risk of thrombosis, but yes, in a desperate situation, and if the patient, if the facility has got this available at that stage, this factor 7A can also be used, recombinant factor 7A. So, Dr. Punita, are you there? Dr. Punita? Dr. Punita, I think there is, I hope she's there. Anybody else of our panelists would like to take this question? What are the precautions during delivery or cesarean in such a patient where you know already that there is a background coagulopathy, like this case of AFLP, or sometimes we have a case of HELP syndrome. So we know they may have PPH. So what kind of precautions we should be using in the delivery or cesarean of such cases?
In such cases, we can give prophylactically tranexamic acid.
Yes, okay.
That is all. Otherwise, also we are giving before normal delivery or cesarean, one antibiotic shot and one tranexamic shot.
But
This is
products
given.
and FFPs should be kept ready.
Everything should be kept ready to handle PPH. That is the main thing.
Yes. So we should have, very true, Dr. Yeah. So we should keep the FFP ready. Dr. Anuba and Dr. Pragati have given their inputs. I think we can just add that senior most obstetrician should be available to deliver, even if it is a normal delivery. Don't leave it on the junior residents or the intern doctors. Acute liver failure patients, and when there is already background of coagulopathy, supervise even the episiotomy, because the hematomas are very notorious in such cases. So always have a good team to conduct deliveries here. Correct the coagulopathy before any operative intervention. Ideally, we should correct, but definitely we may not have time. So you go to the surgery with enough blood products. Put a intraperitoneal drain after cesarean section. Always we do this thing, because later on, if she starts oozing, we will not come to know early that there is a bleeding from the stitch line. Strict vigilance for 24 hours postpartum should be there. She should be managed in a HTU setting, and anything, even we know that in AFLP especially, hypotension can precipitate encephalopathy. So we have to be very, very cautious about hypotension developing. Strict hemodynamic monitoring, maintain the fluid and electrolytes, and keep a very vigilant eye for infection. And I request Dr. Chitra to add any more value-added, tip from her side for this case.
First of all, any case of acute liver failure with pregnancy and everything, first of all, should not be attempted in a small nursing home. And this patient has given us time. I mean, it was early labor. We would have had time to shift the patient. That is one thing. Secondly, if suppose a patient is delivering in your place, keep the whole help team informed and ready. There are some times in small nursing homes where an anesthetist is not available, the blood products are not available. So all these should be ready before the patient delivers. Your help team should be ready, whether you require it or not, but they should be available and they should be in the hospital. As if you're taking the patient for a cesarean, your whole team is there. That is very, very important. These two things: maintain 2 vein lines ready with a good IV cannulas before you take up the thing. And of course, as you've already said earlier about your help team being ready, about the blood products being ready, and the senior most obstetrician of that place to be there. And call in one more person also. Don't manage these things alone. Because there are things, you know, in private patients, they say, okay, I am doing it alone, and there's very few, a second help there in small nursing homes. So if necessary, get one more person definitely there. Don't try and manage a delivery of such a patient alone. Because these, I'm talking about the practices thing, not in a hospital. When you're in a big hospital, you have your juniors, everything with you. But we are talking about UP, which has the maximum PPH incidence also. And there are a lot of small nursing homes that there's one gynecologist who's managing all that, one sister. That's about it. That is the team. So if required, help should be called from nearby places so that at least you have 2 gynecologists, 2 sisters ready. And your PPH kit should be ready in the labor room before you go in for any form of delivery. OT should be ready. All this is, you know, practical guidelines before we are talking about management of PPH. We should be ready for all this.
Josna ma'am, I will like to add 2 things. In this particular case, because she's a case of acute fatty liver of the pregnancy, hypoglycemia is very, very common.
Yes.
So sugar monitoring is very important. And secondly, these patients requires albumin more rather than other drips, because I have managed one case in tertiary center. So that's why our anesthetist was insisting to give albumin till it get
After
corrected.
the acute phase is settled, we do give albumin many times to such patients. But in the acute stage, we don't use the albumin for resuscitation as such. Later on, we do give it to the patient when they are, settled after the acute phase is over. But yes, that sugar monitoring is very important. We do hardly, and normally we will start, 20D, 25D at times you have to give, but 10D is what we start at the rate of say 30 ml per hour along with the other fluids. So that keeps, the sugar levels under control. And Dr. Shashi Lata Kabra, she has given a very important message in the chat box about NASG as a life-saving garment. It is high time that it should be made available in all referral centers during transfer and also in tertiary hospital with heavy load for circumstances like busy OT. And if the other patient is, waiting and in shock, in the meantime, you can put the patient on the NASG garment till the OT is available. So, and also about the PPH toolkit she has written. So I think very important advice from Dr. Shashi also. So now, Dr. Shiba, I request you to carry on the session with the next 2 cases.
Yes, thank you, ma'am. So beginning with the case 2, she was a para-1 live one with previous vaginal delivery 12 hours back, who was referred to Safdarjung with history of traumatic PPH with cervical and vaginal lacerations and PAC in C2. On examination, she had tachycardia and hypotension. Her blood pressure was 90 by 65 millimeters of mercury. Her respiratory rate was 28 per minute. She had a saturation of 97% on womb air and pallor was present. She was around 6 gram percent clinically. On per-abdominal examination, her uterus was 20 weeks size, was well contracted. On local examination, the PAC was partially soaked. So my first question goes to Dr. Pragati Agarwal, ma'am. Please outline broadly the steps of management in such patient.
This is a case of traumatic PPH. As the uterus is well contracted, this is uterus is not atonic, and it is not actively bleeding at present because there is a PAC inside the uterus, inside the vagina. Therefore, first I will manage her and I will keep ready the blood products so that whenever I will remove the PAC, then I have the blood in my hands. First, I will start the packed cell transfusion, and then I will call the anesthetist and I will keep ready. I will remove the pack and then I will see from where I will manage the cervical and vaginal delivery.
Yes, very
And
well said.
yes.
So we will institute a bundle approach of FIGO for PPH management. And the important take-home messages for this case is that while we're preparing the patient for laparotomy, we have to take her to OT, and under adequate anesthesia only, we should attempt to remove the pack, explore, and proceed accordingly. And should not try to attempt without resuscitating the patient and making adequate preparations for laparotomy in the casualty itself. So the cervical exploration was done in this patient, and a cervical tear of around 6 to 7 centimeter was noted at 6 o'clock position with the right lateral vaginal tear, and the apex, however, could not be reached vaginally. So, Dr. Anubha ma'am, how should we manage the situation now?
Anubha, you are muted. Anubha.
This is the case of traumatic PPH, and we can't reach the apex. So without wasting any time, we will tightly pack the vagina and we'll shift the patient to the OT. Keep the blood products ready. Anesthetic should be informed, and we'll ready for the vaginal exploration from the lower side to repair the cervical tear. And if under anesthesia the apex is visible, then we will repair the this tear from the lower end or the vaginal side, or we should take the consent for the laparotomy also, whether it is supralevator hematoma and all, then we will do the exploratory laparotomy. So only so we will repair this.
So it was like 6 to 7 centimeter tear. That means the entire cervix was gone. So it was a complete colporexis only. And for this patient, as you have very well highlighted, that we must undertake preparations for laparotomy immediately, and then definitive surgery, which might include hysterectomy after resuscitating the patient. Now, laparotomy was done in this patient, and a big broad ligament hematoma of around 6 to 7 centimeter corroborating the findings was seen on the right side. So how should we tackle this, Dr. Alpana ma'am, and what are the challenges and alternatives?
Yes, it is a broad ligament hematoma. We first explore and enter leaf of the broad ligament and explore all the hematoma and find the bleeding vessels. If we find, we will ligate it and see is bleeding is stop. If not stop, we ligate uterine artery and ovarian artery, and be very careful regarding ureter. Ureter should not be tight or injured. Very, very careful regarding ureter. If after tightening uterine artery or ovarian artery, if bleeding stop, is good. If not stop, then we go through internal. We give aortic clamp. V pili aortic केरला साइड पे V pili aortic clamp अवेलेबल है, हम aorta में clamp लगा देते हैं and release after 10 minutes. इससे क्या होता है, ब्लड लॉस बहुत कम होता है, हम सारे ये जो ऑपरेशन है वो कर सकते हैं आराम से, वेरी मिनिमम ब्लड लॉस पे. देन वी गो थ्रू we do internal iliac ligation. If bleeding is stopped, then good. If it's not stopped, then hysterectomy is the last resort.
Yes, very well said, ma'am. So we must.
One very important point we have to remember that this patient was relatively stable when she came into you. So make sure your documentation has been right. All the risk factors have been explained. The signatures have been taken before you go into any intervention. Because any case of PPH, one person has to explain to the relatives what is happening, and signatures have to be taken at every stage, because that is where we all get stuck. And later when something happens, that they can even ask you, why have you done a hysterectomy? You haven't asked me. So this is a very important factor that nowadays in today's medical legal age, this is where most obstetricians get stuck and they are sued. So nobody says about how the patient came in, what was done, where was she delivered, nothing. It's the treating doctor at that particular time who goes into a fix. So make sure that your documentation is right at that particular time before you take up the patient into the OT, the labor room, anywhere.
And you can also make the video recording of
well, it's
whenever
very
you are explaining,
make
whenever
video
you are
recording, but
no, you can stand in front of your cameras. Cameras are already everywhere in hospital. In every room we are having, you can go in chamber and explain the patient, so that video recording is also there and written consent is also there. at
Yes,
every step.
absolutely said by Chitra ma'am that documentation is important at each step, and debriefing the patient and or her relatives if she's not in that situation at each point of time is very important. Where the pin girl approach comes, where one of the members of the team is assigned this task only to tell the patient and brief about the current situation. So as in this case, so we proceeded to stepwise revascularization, and as ma'am said that if the blood loss did not stop, then we must go ahead with internal iliac artery ligation as well. And this would be tackled with by Dr. Shashilata ma'am in a beautiful video presentation following our panel. So I would not, this is a very important and pertinent skill which is required by all the gynecologists, and all obstetricians must have this in their armamentarium. So it is a very non-invasive approach where the adventitious sheath is clear. There are different approaches that will be also discussed, and there are hardly any complications if you acquire this skill and learn it with time. And arterial embolization can also be done, but it is generally not available. So ligation should be there, and then low recourse to hysterectomy should always be there. So Chitra ma'am, before we go to the third case, if I would request you to give any other expert comments. Ma'am, you're muted, ma'am.
Whatever you've said is completely covered the whole thing as to what are the things you can go to. Uterine artery, internal iliac, all that, and final hysterectomy. There isn't, I mean, you've covered everything in this management.
Okay. Thank you, ma'am. So now proceeding to the next case. So she was Mrs. X, a 25-year-old, unbooked para 1 live 1 A3, who was admitted through gynae emergency in Safdarjung Hospital on post-surgery day 8 of a preterm vaginal delivery. She came with complaints of pain abdomen since last 2 days and bleeding per vaginum also since last 2 days. She gave history of soaking 4 to 5 pads, which was fully associated with passage of clots. She had history of 3 spontaneous abortions in first trimester in her obstetric history, and each was followed by dilatation and curettage. Her last delivery was a preterm delivery at 32 weeks, where she delivered a 1.6 kg baby who was then admitted into the nursery. So on examination in the gynae casualty, her general condition was fair. She was afebrile, had stable vitals, but she was clinically pale to the tune of 7 gram%. On per abdomen examination, there was no evidence of any organomegaly. Her uterus was corresponding to 16-week size, though was well contracted. On per speculum examination in the casualty itself, mild bleeding was present, but no clots were visualized. Per vaginal examination, the os was parous, uterus was corresponding to 16-week size, anteverted, mobile, and bilateral cornices were free and non-tender. So we performed an ultrasound with color Doppler, and this was the image which we saw. So patient was admitted for observation in the ward. Her routine investigation was sent, which came with normal limits, except for the HB, which corresponded to 7.2 as we guessed clinically. Her ultrasound pelvis was done, which suggestive of a postpartum uterus with a heterogeneous collection of 6 into 3.5 centimeter on the posterior wall with increased vascularity. This was the image. So my question, Dr. Deepa has not joined, so I would like to request any of the panelists to take this question. What would be the differential diagnosis for this case? Pragati ma'am, if you could chip in. And how would you proceed to manage this case? Should we proceed for dilatation and evacuation directly? And if we do that, what would be the risks in this case? Dr. Pragati ma'am?
We should not proceed for directly for dilatation and evacuation. This is a posterior.
So what
these are the vascular retained products.
Yeah. So
the products are adherent posteriorly.
Yeah. So ma'am, this as the picture was, it showed a 6 into 3 centimeter heterogeneous collection in the posterior diameter of the uterus with increased vascularity.
This may be AV malformation. This may be AV malformation, or there may be gestation trophoblastic disease (GTD).
So the vascular RPOC was the first one, and then adherent RPOC or the PAS as we say, and then the other differential which we would have kept in mind was AV malformation and a query gestational trophoblastic disease. So in this patient, then we have this facility in our hospital. So uterine artery embolization was done, followed by suction evacuation the very next day. And then, so uterine artery embolization is a very non-surgical, minimally invasive, which is done in hemodynamically stable patient, as in this case, and it is a higher success rate of 95%. And the gel foam or the PVA particles are used, and very minimal complications are there. So, Dr. Punita ma'am, what are the indications of uterine artery embolization in PPH patients, and any complications of uterine artery embolization which you would highlight? And what could be the outcome for future fertility in patients who undergo uterine artery embolization, as in our case? I think Dr. Punita ma'am is also not there. So, Dr. Anubha ma'am or Dr. Alpana ma'am, if you could say, or Dr. Pragati.
If the PPH is not controlled by the by any surgical method or atonic, like there is atonic PPH or there is traumatic PPH, and we are not able to control it, then we can do a uterine artery embolization. And this is a non-surgical procedure. And there is the blood supply of the uterus will be less, then we can manage the case easily. And there are no complications of uterine artery embolization, but only the main thing is that this facility should be present.
The synechia can be formed in these type of cases, and so in the future fertility can affect it because of the synechia, because of adhesion formation.
Why synechia? Why synechia will be formed?
Because some Pragati ma'am, there may be some ischemic necrosis because of the uterine artery embolization.
Yeah, but we are doing uterine artery ligation also. Then there are studies that it doesn't
embolization. This is uterine artery embolization. This is
both,
not.
I think both should be the.
See, but in the ligation, all alternative channels or they are formed. But in the
embolization does affect future fertility.
Yeah.
That is one important aspect. If she's completed her family, it's a different issue, but she doesn't. So
ma'am, she had one preterm delivery. And the baby
one preterm delivery. That's about it, and that's a 1.6 kg baby.
So, but this is a non-surgical, minimally invasive, which has to be done only in hemodynamically stable patients if you have the facility. And the important thing is that it does not have many complications. And the procedure is very simple once you have your intervention radiologist in place. When IV hydration is done, bladder is catheterized, antibiotics are given, just NSAIDs for painkiller before the procedure. Femoral access is gained by, the arterial access is gained by femoral artery, a diagnostic angiogram is performed, and then super selective catheterization using microcatheters is done. And then embolization is done by using gel foam or the PVC particles. And these are the pictures before the uterine artery embolization and post embolization. And the advantage is that the GA is avoided, the surgical incision is avoided, there is no blood loss or risk of blood transfusion, as a shorter recovery. But there are few complications, mostly are immediate, which are local complications like groin hematoma during arterial access or arterial thrombosis and dissection or pseudoaneurysm. But then most common complications are the early complications which occur within 30 days, which is the post-embolization syndrome, which patients often complain like pain, nausea, fever, and malaise. But this has to be managed absolutely conservatively, as it is self-limiting in 10 days to 2 weeks. And then very few patients would have late complications like persistent vaginal discharge or persistent discharge, and if it is foul smelling, and some may also say that it may cause inuria. And regarding the future fertility, it has been reported that pregnancy is there after uterine artery embolization, though long-term effects are not known. And the studies available are like the largest one is the Ontario trial, which was done from 1998 to 2000 women. 2000 on 555 women who underwent uterine artery embolization for various reasons, and out of them 21 conceived and 18 live births were there. So women are able to achieve pregnancy, though those rates are decreased, and because it causes a decreased flow in uterine arteries and maybe an early menopause, which is age dependent in 2 to 6% patients. But close monitoring of the placental status in future pregnancy is warranted. So, Dr. Chitra ma'am, before we end this case discussion, if you would like to chip in for some expert comments for this case.
Dr. Shiva, is it this is uterine artery embolization by using the balloon also?
Ma'am, this was uterine artery embolization.
Gel foam. These are gel foam.
Gel foam.
The balloon one is called the uterine artery balloon occlusion. That has also come up. Yeah, the balloon occlusion has also come up these days, but it is not available everywhere. It has come up in big time in US and UK, but in India it is.
That is much safer. That is much safer.
Yeah, ma'am, it has
Yeah,
been.
that is known to be safer, but here we don't have that. So it has to be with the gel form only.
So that
And
is
it's one of the fastest and one of the least invasive procedures right now for this case.
Yes, ma'am. The balloon occlusion has been proposed to be safer, and we are waiting that it comes up in big time in India also.
Because I have read ki in the cases of placenta previa, in which we know ki the bleeding can occur, so prophylactic balloon insertion can be done in the deflated
Placenta
position
accreta.
and
Pass.
placenta accreta or previa. So as soon as we delivered the baby and all the surgical intervention fail, then we'll simply inflate that balloon.
Balloon is intra-aortic balloon tamponade, and it is done, and even in the uterine artery also. So it is basically the occlusive effect, and it decreases the blood loss, and it has minimal risks, and it has been proven to be safer. But as ma'am had already highlighted, that is not available here as of now, and we are waiting.
Yes.
That we do.
We use what we have right now. And
Yes, ma'am. So to summarize, so PPH, as we have all been told, the PPH drill is very important, and these mnemonics, which our postgraduates who are attending this webinar must know, that is the hemo and the stasis. The hemo is all the medical management, and stasis is all the surgical management, with the UBT, the balloon tamponade, as the first step once the medical management fails. And whatever be the patient, either she was hemodynamically unstable from the starting, or she deteriorates very rapidly, is the golden hour is very important. There should be an early recourse to hysterectomy, even if we do not have the other methods available with us. So the decision time is very important. And FIGO, as Jyotsna ma'am had already highlighted, and Sadhna ma'am has also highlighted, that it really advocates the bundle approach, where every unit should be ready for management of PPH with the infrastructure, the hemorrhage card, the immediate access to hemorrhage medications, response team to call when help is needed, massive and emergency release transfusion protocols should be in place. Unit should be educated on these protocols, and unit-based drills should be there. Then the 4 R's, besides readiness, has the recognition and prevention, that is assessment of hemorrhage. As ma'am said, that in stage 1 and stage 2, the patient does not become symptomatic soon, and we must assess, we must know the obstetric warning symptoms. The measurement of cumulative blood loss, because under reporting of the blood loss, especially the visual estimation is always there. And active management of third stage of labor is important. And then the response and the reporting. So response is that once PPH occurs, there should be a uni-standard stage-based obstetric hemorrhage emergency management plan with checklists in situ and support program for patients, families, and staff for all significant hemorrhages. Because patients, they must be given the support once they go through this massive PPH. Their families, they should be also as ma'am told, that Chitra ma'am said, that they should be debriefed at each time, and the staff also who were managing this patient and attempted to save, and then became successful also in many instances for the significant hemorrhages, they also need the support. And then as any incident must be reported, so reporting systems should also be in place, because we must learn from every incident, and we should try not to repeat this, and to try to save every life which we come across. So establish a culture of huddles for high-risk patients and post-event debriefs to identify the successes or missed opportunities. The multidisciplinary review of serious hemorrhages for systems issues should be done, and outcomes monitoring and process metrics in perinatal quality should be done. So PPH is a serious life-threatening obstetric problem, and is a forerunner in all near-miss audits all across the country. And it is a major cause of mortality and morbidity, where too little is often done too late, and golden hour is pivotal. We must try to avoid mistakes. So resources which are even well equipped and staffed units may be stretched at the slightest of the incidents. And then the bundle approach should be in place with facility readiness, the 4 R's, the response, and the recognition and reporting also. And data monitoring and quality improvement should be there. So however difficult the life may seem, there's always something we can do and we succeed. So thank you.
One more thing I'd like to add before you get out of the OT or the labor room or everything, ensure that all the ampules are there.
Yes,
and before you get out, all the records of what you have written, what your resident has written, what the sisters have written, all those records should be in symphony. Not that the sister has written that this has been given, the resident has written this has been given. So make sure before the patient gets out and before y'all get out, all these documentation is also very, very important. In all these PPH cases, that is very important. And keep those ampules, because you never know what ampule may be missing. And that record is also very, very important. Because also check sometimes, somebody goes and says that this was done, this was done. So ensure that everyone is around, and this documentation is very, very important. Whatever you do, very good. And you save a lot of patients, but you never know what may happen. So your documentation of all these and documentation of all 3 notes should be not
incorporated.
Yes, ma'am. So, because when in emergency, we are busy in managing the patients. So even if one person is jotting down, at the end of the day, we must take out some time to make that documentation complete. And it, as you said, that it should be in sync with all the vital parameters, the anesthetist, the nurse notes, and everything should be in place before the patient goes out. Thank you, ma'am.
That was a wonderful panel with very interesting cases and very informative inputs we have got. So now let us quickly move towards a very interesting video. Thank you to our moderators and our panelists and our expert panelists for such wise inputs. So quickly moving to a very interesting video session by Dr. Samarth Ram. And for this session, I would like to invite our esteemed chairpersons, Dr. Mridula Sharma. She is president of Bareilly Obs and Gynae Society and director of Dharamdat City Hospital, Bareilly. She is Manyata Foxy lead assessor and member of Safe Motherhood Committee Foxy, recipient of Foxy Appreciation Award 2023 and the President's Appreciation Award and PSC Award. Her areas of interest being high-risk pregnancy and adolescent health. A very warm welcome to you, Dr. Mridula. Then we have with us Dr. Aradhana Singh. She is president of Noida Obs and Gynae Society, additional director Obs and Gynae Fortis Hospital, Noida. She is organizing secretary of the North Zone Yuva Foxy 2019 and secretary of Noida Obs and Gynae Society from 2013 to 15. She was joint treasurer NOX and she's recipient of Young Talent Contribution to NOX in 2016. Her areas of interest being high-risk ops, endoscopy, endocrinology, adolescent gynecology, colposcopy, gynae ultrasonography, and menstrual disorders. A very warm welcome to you, Dr. Aradhana. Then we have Dr. Shweta Mathur. She's done her endoscopy training from AIMS. Her area of interest is gynae ultrasound and hysteroscopy. She's past treasurer NOX. And experienced orator and speaks well on women's health and wellness for various MNCs. So I invite our chairpersons and I hand over the session to our chairpersons to invite and introduce our speaker, Dr. Samarth Ram.
Thank you, ma'am, for the warm introduction. And I would like to invite Dr. Samartha Ram. He is Director and Head of the Department of Obs and Gynae, Sandhya Ram Hospital, Palakkad, Kerala. He is the winner of prestigious senior category Foxy Korean Award, 3 times winner of Dr. C.S. Dawn Prize Foxy Pico Award. He is Fox President Gold Medal and Yuva Foxy Award. His PPH suction cannula and oral hydration therapy to prevent severe preeclampsia could bring down MMR very significantly in Kerala, Tamil Nadu, and AP. Publications has published 26 original papers in national and international journals, especially interested in postpartum hemorrhage, preeclampsia, and amniotic fluid optical density guided induction of labor.
Am I audible? Good evening. Hello. Good evening.
Good evening, sir. Welcome.
Yes. Good evening, chairpersons, and good evening, everybody.
It's a pleasure to.
Yes. Yes, make it. Good evening, chairpersons, and good evening, everybody. Very much thankful to the organizers, especially Sadhana Gupta ji, for giving me this opportunity. And I wish her best of luck in forthcoming presidential election. One important observation what I could observe here is SR cannula is not very popular in North India. Cannula is very popular in South India. Everywhere, every hospital nowadays, even every nursing home, they're keeping this ready. And the PPH maternal deaths, hemorrhagic deaths have come down very significantly. SRPPH suction cannula and oral hydration therapy to prevent severe preeclampsia are the two main reasons for bringing down maternal mortality very significantly in South India. If you go into the terms of MMR Kerala, it is 19 now. In Tamil Nadu, it is around 45, 50 now. And in same thing with Telangana, same thing with Andhra Pradesh also. I have covered almost 4 southern states here with this suction cannula and OHT, and we are expecting further gross reduction in MMR by the end of this year. The title of the topic I'm presenting, SRPPS suction cannula for the management of atonic postpartum hemorrhage. Greetings from God's own country, Kerala. Postpartum hemorrhage is the leading cause of maternal deaths all over the world, amounting to 28%. Around 50% of the mothers die due to atonic PPH. When conservative methods like uterine massage, uterotonic drugs, and balloon tamponade fail, surgical interventions which need laparotomy are needed to stop bleeding. In low resource settings, it is difficult to organize competent manpower, compatible blood, and transport to higher medical centers. Many times, mothers die on roads while being transported to higher medical centers. This is the SRPPH suction cannula which I have developed, measures 23 centimeters long, and this fundal portion is having larger holes, cervical portion is having smaller holes. This vaginal portion do not have any holes. This is the nipple of the cannula which stays outside the vagina to be connected to the suction machine through tubing like this. Coming to the mechanism, how it works. This is the atonic uterus bleeding profusely, cannula inserted here. When negative pressure applied, the soft cervical tissues get sucked into the perforations of cervical portion of the cannula and become adherent. Uterus becomes a closed cavity. Further continuation of negative pressure results in constriction, contraction, and firm retraction of uterus on the surface of the cannula, which assists the natural physiological process of contraction and retraction to stop atonic bleeding. I am showing the uterus here during surgery, during cesarean section. Cannula is there inside uterus and it is creating powerful negative pressure. You can see the global constriction of the uterus, both upper and lower segment, because the powerful negative pressure inside the uterine cavity working. It is not rugosities. You can see coarse ridges on both upper and lower segments. For the same reason, cannula is very effective to stop bleeding from lower uterine segment, even in case of placenta previa. I would like to say once again, SR cannula is very effective to stop lower segment bleeding in case of placenta previa. Achieving closed uterine cavity is a basic and fundamental requirement for the functioning of suction tamponade system. 5 different sizes of cannulas are made to match different cervical dilatations and to match different uterocervical lengths. Different obstetric bleeding situations have different cervical dilatations and different uterocervical lengths. This is a post-abortal uterus. Uterocervical length is very small and cervix admit only one finger. You have to use a thin diameter cannula, low diameter cannula. Whereas a postpartum uterus, cervical dilatation is up to 8 to 10 centimeters. You have to use a larger diameter cannula. And it is the suppose if you use a thin cannula in a immediate postpartum uterus, this thin 1 centimeter cannula stay in one corner of the cervix, cervical canal, and it is difficult for the cervix to catch it, and so it fails to create a closed uterine cavity, and it is not very much effective to stop atonic bleeding. These are the cannulas designed for atonic PPH after vaginal delivery. This cannula is for a dilated cervix. This cannula is for cervix admitting one finger, lateral view, and AP view. These are the cannulas designed for atonic PPH during cesarean section. This is the cannula Larger diameter cannula for dilated cervix. This is a thin cannula meant for cervix admitting one finger. Suppose if you try to insert a larger diameter cannula in a thin cervix admitting one finger, it will not go inside. So you have to select the cannula before you plan for cesarean section itself based on the cervical dilatation. This is a cannula designed for bleeding after MTP or vesicular molar extraction. So this is a thin cannula which in these cases cervix admits only one finger. The whole index is different for this cannula here because the uterocervical length is short. And this cannula is also used as a suction tube introducer while doing a cesarean section. When compared to balloon tamponade system, in balloon tamponade, the mechanism is totally opposite. Here, the water-filled balloon dilates the uterine cavity and the distended balloon compresses the bleeding sinusoid to stop bleeding. On the other hand, the vacuum tamponade system assists the natural physiological process of contraction and retraction to stop atonic bleeding. SR cannula application for atonic PPH during vaginal delivery. Here I will show a small video of clean-cut PPH.
Woman bleeding profusely. Vagina retracted with white blood speck like this. 5 centimeters of anterior cervix is caught with the sponge holding forceps like this. Cannula inserted. Tip of the cannula should be at the level of fundus and should be felt bimanually. Nipple of the cannula should be connected to the suction machine through tubing. Negative pressure should be applied. A negative pressure of 650 millimeters mercury should be applied for 10 to 15 minutes. We can see complete cessation of bleeding within 4 minutes. Retracted well.
In fact, this video was recorded in the year 2014, and so many modifications have occurred on the design of the cannula. Those days, this is the first case which I have recorded, and here I have inserted the cannula inside, then we connected the suction tube to the cannula. Nowadays, we don't do this. We keep the cannula connected to the suction tube before the delivery of the baby. So the entire system is organized. Then without wasting much time, within 45 seconds, we can insert the cannula and apply negative pressure. Application of negative pressure. A negative pressure of 650 millimeters of mercury should be created and maintained for 10 to 15 minutes. And then the machine should be put off. There's no need to maintain negative pressure for a long time. You have to apply negative pressure only 10 to 15 minutes only every hour. This procedure should be repeated every hour for 2 to 3 hours. After 3 hours, the cannula should be kept in the same position without removal and should watch for bleeding. In case of recurrence of bleeding, negative pressure should be applied by just switching on the machine. If you just switch on the machine, the bleeding stops. How long to keep the cannula inside the uterus? Usually, the cannula can be removed after 6 to 8 hours. In case of high-risk women, cannula can be kept inside uterus as long as the bleeding expected, even up to 24 hours. Whenever there's a recurrence of bleeding, we can put on the machine. How long to keep the cannula inside and how long to apply negative pressure? These are at the discretion of the obstetrician. The guidelines what I have given is general guidelines. Suppose the woman starts bleeding within 20 minutes, 30 minutes after first application of negative pressure, you need not wait 1 hour. You have to apply negative pressure. These are all at the discretion of the obstetrician managing the case. SR cannula application for atonic PPH during cesarean section.
Cannula system should be organized while setting the trolley itself. The intended cannula for application should be fixed to one side of the suction tube. Other end of the suction tube should be fixed with a thin long cannula. As this is an elective section, I am dilating this cervix with index finger. I use thin, long cannula, which I call it as a number 5 cannula, as a suction tube introducer. Suction tube should be connected to the suction machine. Cannula should be kept in proper position like this. Cut edges should be kept close together. Mop pressure applied. Negative pressure applied. You can see complete cessation of bleeding, contracted and well retracted uterus. You can see practically no bleeding. I am closing the left angle under direct vision. Contracted and retracted uterus. Blood loss less than 100 ml.
I would like to share some information here. When before you apply cannula, there's no need to suture the uterine wound to apply negative pressure. You can just keep the cut edges together and apply negative pressure. Because of valvular mechanism, the cut edges come close together and itself will form a closed uterine cavity, and the negative pressure starts working and uterus starts contracting and retracting. When you apply cannula during cesarean section, you can virtually see how the uterus contracts and retracts. The uterus retracts, retract within just 1 minute, 1 to 2 minutes time. And what I advise is, after application of negative pressure, don't disturb anything. Just leave it for one minute. Keep just watch how it works. Not only that, whatever the blood in the muscles of the uterus, once the suction cannula system starts working and the entire blood go back into the circulation, uterus gets shrunk and it become pale, and then you can start suturing the uterus. Foley's catheter, tourniquet, and SR cannula for lower segment bleeding while doing cesarean section. This is a technique which I have developed for cases of placenta previa, central placenta previa, and so on. Immediately after exteriorizing uterus, we apply a tourniquet with a Foley catheter on the lower segment. All the vessels supplying the uterus get blocked and bleeding stops instantaneously. This technique is developed for peripheral centers with suboptimal facilities. This can be used in any hospital. Now,
as Foley's catheter is elastic, it permits the application of SR cannula with in situ tourniquet.
you have to position the cannula in a proper position, keep the cut edges together, apply pressure with a mop, then apply negative pressure. You can see uterus getting contracted and retracted. Then
you can see complete cessation of bleeding with contracted and retracted uterus.
prophylactic application of SR cannula is done for women who are at high risk for developing atonic PPH, like in case of pregnancy-induced hypertension, anemia complicating pregnancy, and accidental hemorrhage, and so on.
For prophylactic application, we have to check the suction machine before the delivery itself for proper functioning. And we have to organize the cannula system. Cannula should be firmly fixed to the one end of the suction tube. Other end of the suction tube should be firmly fixed to the suction machine like this. After the delivery of the baby and before the delivery of the placenta, vagina retracted with white blood speculum, mild traction on the umbilical cord, 5 centimeters of anterior cervix caught with the sponge holding forceps like this. After the delivery of the placenta, without wasting any time, Left two fingers inserted deep into the cervix. Cannula inserted into the uterine cavity, taking the guidance of left fingers. Tip of the cannula at the level of fundus. Negative pressure applied. You can see complete cessation of bleeding. Total blood loss is around 50 ml. Uterus retracted well.
What I would like to suggest here is in small nursing homes, in peripheral PHCs, CHCs, where suboptimal facilities are only available, such places, I would like to advise them to apply cannula for every normal delivery and every cesarean section. If cannula is applied, the blood loss during cesarean or normal delivery is about less than 200 ml. The one important factor which worsen the cascades, especially in a critically ill patient, is the bleeding. If you can stop bleeding, even if the woman is in coagulation failure or acute hepatic necrosis, any such thing, or multi-organ dysfunction syndrome, even if the patient is there, that particular critical moment, one important factor, which makes the things go worse and results in maternal death is the bleeding. If you can stop bleeding by applying SR cannula, you will have time to correct the coagulation defects and you can save the mother. SR cannula for traumatic PPH. I suggest to apply SR cannula for every case of PPH, whether it is traumatic or atonic. In cases of advanced traumatic PPH, some amount of uterine atony is always possible. Cannula corrects this atonic component and reduces bleeding. When negative pressure applied, the cervical tissues get firmly sucked into the holes of the cervical portion of the cannula and become adherent. The cervical tissues when the cervical tissues firmly adhere on the surface of the cannula, the blood flow in the descending cervical vessels will come down and the bleeding from the cervical tears or vaginal tears will come down. And you need not apply sponge holders to hold the cervix. If you apply traction on the suction tube and cannula, the entire uterus en masse descends down. You can apply speculum at a good source of light. You can suture the cervical tears or vaginal tears. Because blood is not coming down from the uterus, because blood from uterus will go to the suction bottle, and you can see the tears well, and you can suture the wounds, cervical tears and vaginal tears better, and we can prevent blood loss. SR cannula for transporting the woman with PPH. This is the manual suction pump what we use for transporting the woman for a tertiary care center. There's no need to go on massaging till the patient reaches. Those days are gone. If you apply cannula, if one suction pump is given to the ANM or ASHA worker or even a staff nurse, she can apply negative pressure and she can reach the referral center without maternal death on the ambulance.
Manual suction pump can also be used to create negative pressure inside uterine cavity. This is useful in places where there is no power and also helps to transport the patient with in situ cannula.
How to remove SR cannula after the procedure? After the completion of the procedure, the cannula cannot be removed easily as the soft cervical tissues get sucked into the perforations of cervical portion of the cannula and become adherent. Cannula can be removed easily.
Cannula can be easily removed after gentle separation of these adhesions with finger manipulation like this.
This is the case of C-section we did last night. Next morning, we are trying to remove the cannula here.
Are you able to see now?
You have to insert the index finger between the cannula and the cervix and slowly go on detaching the stuck cervical tissues into the holes of the cannula. Once the adhesions are released, the cannula come out easily like this. Then how to clean the cannula?
To clean the cannula, immerse the cannula inside water. Kink the suction tube and put on suction machine and create high negative pressure inside the suction bottle. Then release the kink. By gush of entry of water inside the cannula get cleaned.
Then the question is whether SR cannula can produce inversion of uterus. SR cannula do not produce inversion of uterus, but inversion of uterus can be treated with SR cannula. In a case of inversion of uterus like this, you have to reposition the uterus back into the abdomen. You have to insert the cannula into the uterine cavity and apply negative pressure. The atonia of the uterus disappears and uterus get fixed there, and it will become rigid and get contracted, retracted, and the recurrence of inversion do not occur. The cannula is also very effective to stop uterine bleeding, even in case of coagulation failure. This is a case of cuvillary uterus with coagulation failure. SR cannula was used. You could save the mother and her fertility function. This SR cannula was very liberally used during the period of COVID-19 infection in many medical colleges, which include Visakhapatnam and Thrissur here, and they could manage cases of COVID with the coagulation defects successfully, and they could save the mothers. Cannula do not do anything with the coagulation defects in the blood, but it stops bleeding. Once bleeding is stopped from the uterus, uterus is the main source of blood loss. Once we stop the bleeding from the uterus, you'll have time to correct the coagulation defects in the blood. Further, if there is any difficulty, you can call me to this number. I've given my number here. Many cases we could save. Many critical hour they call me like this. I sit on here and manage the case, and I do make them apply cannula and save the mother. I would like to share some information how rapidly SR cannula system is spreading in South India. Under care of Government of Andhra Pradesh, SR cannula and oral hydration therapy to prevent severe preeclampsia and eclampsia were introduced in Chittoor district of Andhra Pradesh in 2018. Hands-on training workshop was conducted at District Hospital Chittoor. Suction cannulas were provided to all institutions conducting deliveries like PHC, CHC, area hospitals, and medical colleges. ANMs and ASHA workers were assigned the job of OHT to all antenatal mothers to prevent preeclampsia. Oral hydration therapy is nothing but making every antenatal mother to consume more than 3 liters of water after 24 weeks of gestation to prevent severe preeclampsia and eclampsia. In peripheral centers with suboptimal facilities, we advised prophylactic application of SR cannula to all women, both in case of vaginal delivery and cesarean section. After 3 months of the starting of the program, we made a review, and you can see how wonderful results we have here. And you can see here, and 8,400 deliveries took place. Within 3 months' time, 1,500 applications of SR cannula was done. And you can see not a single maternal death occurred due to PPH. For 8,000 and odd deliveries, only 28 units of blood was given. So SR cannula could prevent blood loss, and it could reduce the number of blood transfusions. This is the result after 5 years performance of recently only I could get this information from district medical officer, and I would like to present here. This is 17, 18 only August we have introduced SR cannula here. Before this, during 17, 18, 47 maternal deaths were. Before that, 60, 47 maternal deaths were there. Now, this 2023, 47 maternal deaths has come down to 9 deaths here. The number of PPH deaths were 0. For entire 1 year during 22-23, not a single maternal death occurred for 30,000 deliveries. And if you see here, the maternal mortality from 83, it has dropped to 33. I would like to give some information about OHT to prevent severe preeclampsia. And you can see 17, 18, 16 maternal deaths were there due to PAH, eclampsia and all. And you can see last year, only 1 maternal death was there. To impress on you, the OHT is very effective to prevent maternal death due to preeclampsia and eclampsia. The significant reduction in MMR is due to the combined effect of SR cannula and OHT. Now, entire Tamil Nadu, Kerala, over 80% of Andhra Pradesh and many major hospitals in Karnataka are using this SR cannula to prevent and treat PPH. KFAG had included this device in its obstetric protocols to prevent and treat PPH. This is the 5 years report I'm presenting by the government of India. The MMR dropped in the entire South India. The MMR of Kerala is 19. It has come down to so level which was never before. It's only because of suction cannula and OHT. SRPP suction cannula is a breakthrough innovation to prevent and treat atonic PPH. There's a paradigm shift in the management of PPH now. The panic adrenaline rush of the obstetrician had gone now. This simple, cost-effective, life-saving, and fertility-saving technique. This is a physical method, does not depend on biological factors for its action. For same reason, it doesn't fail. No need to maintain cold chain. Suction cannula system can be organized within 2 minutes time. Bleeding stops just within 2 to 3 minutes time. Cannula system works well even in case of coagulation failure. Even staff nurses can be trained and the bleeding can be stopped without any delay. Highly cost-effective, autoclavable, reusable instrument helps to reduce maternal mortality due to atonic PPH in low resource settings. SR cannula should be made available at every delivery point in the country, and it should be used as a first defense, not as a last desperate resort after failure of all methods. Because by the time you make a decision, a lot of blood is lost. So use cannula as a first defense. No child should become motherless in this country. We should achieve PPH death-free India and PPH death-free universe. Thank you. Thank you. Jai Hind.
So, sir, excellent presentation. And I would like to congratulate you for your excellent work. And just like your name, Samarth, you are able to, the Samarth is who can do everything. So it's a wonderful job. So just want to ask that whether we can replace these steel ones with the plastic cannulas also.
One thing I would like to say here, we are coming out with the disposable cannulas by December, January, we are coming out. But the problem, if I would not have used this stainless steel cannulas, no, I could not have brought down MMR so rapidly. Because one major problem of procuring cannula, because once purchased, need not think of it, need not procuring it. So that's the reason why I opted for this. If I would have gone for a plastic cannulas, I would have made money. But here the target, the objective is to bring down MMR. Second thing, one cannula, once you throw it out, you have to wait for the other cannula come. And whether he may has to go, the sister might have forgotten, and the government may not get money, government may not sanction. There's so many lapses are there. If what I am planning now is they should have one reusable set, and we are going to release this disposable sets by end of January. We are releasing. So whichever they want, whatever they want, they can use it.
And what I feel that in North India, actually it is not that popular as in South.
That's what I said in my first sentence of my talk is that, because nobody, all of you were talking for introduction, everything, but nobody was talking much about cannula except one person. And what I am telling now, we have done one hands-on training workshop at Bodh Gaya district. One Bodh Gaya district we have adopted, and I have given 30 sets to all PHCs, CHCs. 2-3 days I stayed there. I gave them hands-on training workshop. There also the MMR dropped very significantly now.
Sir, may I ask one question?
Please.
Are these SR cannulas or these are the Panikers cannula? Both are functioning same, no?
No. No. That's one
I have taken these Panikers cannula.
I can understand. He is the person, is my fourth co-author. He's not the original author. He's the fourth co-author, and he did all sorts of mischief. And to make my cannula not popular, he made the surgical companies to manufacture and sell it. So every hospital will have Panikar cannula. Most of the things are kept in the shelf only. I have conducted hands-on training workshops in more than 30 medical colleges. Wherever I go, this Panikar cannula is there, but it's not used because it is a fixed model. It cannot apply to every situation. The basic fundamental requirement of the suction cannula system to work is it should achieve a closed return cavity with fixed hole index. If suppose the cannula is applied to a post-abortal, some holes will stay outside. That's in the vagina. They start sucking air. And other thing, In an immediate postpartum uterus, the cervix dilatation about 8 centimeters. Thin cannula, the cervix cannot grip. So you should maintain some volume. Volume, that is the diameter of the cannula, must be a little higher so that it facilitates easy clamping. It is just like clamping of the cervix and the uterus becomes a closed cavity. This more than 30% cases fail with this. That's why actually now this cannula has been thrown out in every hospital everywhere. Everywhere now this is the cannula what people are using. Other thing, no, when the innovation is very simple and very easily can be done, no, everybody will copy it.
Sir, may I ask one question?
Please.
Sir, if we are doing the elective cesarean section in the case of placenta previa, central placenta previa, and after removing the placenta, you said ki put that cannula, but it how it will create a negative pressure so that lower segment it will contract, because upper segment to sir kar jayega, but lower segment ke liye sir open incision is
No,
open.
there is nothing like open side, lower segment or higher segment. I did one workshop at Women and Child Hospital at Egmore, where Madhuliyar sir was there for 30 years. The first workshop we did at Women and Child Hospital. There, Dr. Shobha, the then director, she gave me one central placenta previa case to manage with SR cannula. What I did was I simply opened the uterus and cut through the placenta, removed the baby, and just exterior uterus, applied the tourniquet, which I have shown here. And then I applied the cannula, and we could stop the bleeding totally, and we could complete the surgery with less than 200 ml blood loss. And your question is whether negative pressure can make the lower segment constrict, contract. That's the thing now. That's what exactly you want.
Sir, any cases you have seen with the partial percreta? Of course, the complete percreta will not be
But
affected.
one thing I tell you, there are so many, I mean, entire 4 states they are using this cannula now in South. So many cases, when you open only, you know, it is accreta percreta sometimes. And many of my friends, they have just gave information to me that luckily, sir, cannula was there, we applied, bleeding stopped. Many cases of minor or more than 50-60% of involvement of uterus also, increta percreta also can be handled. Suppose if the placenta has invaded the bladder, bowel, everything, such things I don't know what can be done. But still, what I feel, no, you can remove you can apply a tourniquet like this wherever possible. You can remove the whatever possible adherent placenta. Then insert cannula, apply negative pressure, close the uterus. You can keep 1 day, 2 days, 3 days, 4 days, and nothing will happen. So, see, many applications are there. Many things, there's a lot of potential is there for cannula application, and we are trying now for scar pregnancy also. For scar pregnancy also we are trying. Cervical pregnancy also we are trying. So the results
What is the cost?
Cost is 5 cannulas we are giving at a price of, I am only manufacturing and marketing, and have not given to anybody because they hike the price and make money. So which I don't want. Because of the suction cannula is a reusable, I could cope up the demand. Because I cope up the demand, because once they purchase, it is out. There won't be any sales about that. Actually, I want to kill the business around this. That's why I use this reusable cannulas.
So,
and cost is cost only 11,200 rupees as on today, which inclusive of GST. Set of 5 cannulas.
Okay.
In fact, you cannot make 1 cannula for that price.
Yeah, definitely.
See, it is very useful, and people are very happy with this.
Sir, have you seen any cases of perforation while inserting, or the cervical tears while putting during cesareans?
No, because that's what I told you. When cervix is admitting only one finger, use thin cannula. Smaller diameter cannula. So what you should use, sometimes even smaller cannula also cannot go. That time you have to introduce your finger and dilate it. Then you can apply. Perforation, it is, we have not seen. Now it is 5 years now. More than 5 years now. 2014 I published this paper. And today, about 7 years now, not a single case of perforation. The reason is, that's the reason, if a thin cannula only perforates, When the diameter of the cannula is big, no, it cannot perforate. Recently, I came out with a conical tip on the cannula, so that there was one maternal death at Palakkad. They could not enter the cannula properly because the edge of the cannula was flat and they could not insert. They didn't have time. They were under tension. They took the patient for a cesarean section, and ultimately they could not stop bleeding. It was in a coagulation failure. They did a hysterectomy. Patient died. My baby died. So after that only I thought of on this. Then I came out with a one cannula with a conical tip, so that a conical tip works as a dilator also. Because immediately after placental delivery, within 10-15 seconds, the internal os, the os become constrict and close. You cannot insert even fingers. But in case of frank atonic PPH, you can insert one full hand. That time the cannula goes very easily inside. When for a prophylactic application, when there is no bleeding or little excess of bleeding, this is the model we have developed very recently. We have made the tip as a cone. That cone is also a bigger diameter. It will not perforate.
So we would like to wind up this session. Dr. Sashi has some commitment. She has to give a talk.
Sir, excellent presentation.
Just one thing, when we put the cannula and then on the OT table, when we shift the patient, it stays there. It doesn't move from its place.
I'm not able to hear you. Please.
So can you hear me now?
Yes.
Yeah. So, sir, after the cannula is put on the OT table and then your patient is moved to the bed, the cannula stays there. How do you maintain its position? It doesn't move.
But one thing I would like to say here, I told you this tissues get sucked into the holes. It becomes sticky. It will not come out. That is the self-retaining property. I'll tell you one thing. Hear me. Then we won't remove the cannula in the theater. And along with the cannula, we'll shift the patient to the post-op ward. In the post-op ward, next day morning only we'll remove. Because PPH may recur in the post-op period also. So next morning we'll remove. And in case of recurrence of bleeding, just a nurse only won't call you. Nurse only put on the machine and bleeding stops. I think I'm clear. Okay. Along with the cannula only, what we do now, we'll pull out the suction tube from the suction machine, apply a artery clamp on the suction tube so that blood will not leak throughout the way, and wind it round, make it like this, keep between the two thighs, and then shift the patient to the post-op ward. There, post-op ward, there will be another machine. There you can keep it. Then plug it to the machine and keep it. Watch for bleeding. In case of recurrence of bleeding only, we'll just put on the machine.
Thank you, sir. Excellent presentation and very nice videos. Thank you very much. And thank you, Sadhna ma'am, for giving us this opportunity. This is excellent session going on. Thank you.
Thank you. Thank you very much. I was worried in the between my presentation whether you were able to hear my voice and videos.
Anyhow, thank you. It was very clear, very nice and very clear.
Thank you very much. Nice of you for giving me. I want Sadhana Gupta to come out of this presidential election. Once she becomes president, no, I would like to be more active in North India. I want to see the maternal deaths to come down in Assam. And you have shown a big map of brown color, prominent brown color. We want to do this. This is how my ambition, my liking. We don't mind doing anything for that. Actually, Preeti Kumar is also with me for this mission.
So this was a wonderful discussion. And SR cannula looks very promising. Yes, sir, it will be very popular in North India. You have covered so many states in North India, and everyone seems very interested in your cannula. So yes, it will have it has a very good future, and we will definitely help. It will help in bringing down the maternal mortality.
No, the future is not for me. Future is the mothers of India. They should not die. Yes. They should not die. They should not die.
That's what I meant. It is the patient's future, sir.
Yes. Thank you very much. Kind of you for giving me this opportunity. And
thank you, sir.
Thank you.
And I would like to thank all our chairpersons for this session, for conducting the session so very smoothly. Now, quickly moving towards our last session, that is also very interesting. Stepwise devascularization in PPH, a video demonstration by Dr. Shashi ma'am. And I would like to invite our chairpersons for this session, Dr. Manisha Jain. She's done a fellowship in minimal invasive surgery and in ART. And she worked as an assistant professor in TMC, Muradabad. Now she's working as an IVF consultant in a private setup. She has got the best paper award in UPCOG and has published many papers. She is president of Muradabad Obs and Gynae Society. A very warm welcome to you, ma'am. And next we have Dr. Samta Gupta. She's working as a senior consultant and Professor OBG, School of Medical Sciences and Research, Sharda Hospital, Greater Noida. She's Secretary of Greater Noida Obs and Gynae Society and has presented many papers in national conferences, received the Best Paper Award in Jaipur 2014. She has publications in national and international journals and has area of interest being high-risk pregnancy.
Thank you, ma'am.
Very warm welcome to you, Dr. Samta. And finally, we had one more, Dr. Gayatri Singh, I think. Where is the CV? Yes, Dr. Gayatri Singh. She graduated from MLBMC Jhansi. She's secretary of Bareilly Obs and Gynae Society. She has presented papers in UA Foxy and is practicing for last 30 years. A very warm welcome to our chairpersons. And I would hand over the session to our chairpersons to invite and introduce Dr. Sashi Maheshwari, ma'am.
Thank you, ma'am, for inviting us. So I would now like to invite the next presentation, Dr. Shashi Kabra Maheshwari, ma'am. Ma'am is a senior specialist and a national board examination teacher, DDU Hospital, Delhi Health Services. She's currently the president, Delhi Gynae Forum Southwest. She's chairperson of PCPNDT Committee, West District, Delhi. Ma'am has lot of awards and appreciation, APJ Abdul Kalam Appreciation Award, IMA Appreciation Award. Ma'am has organized 65 workshops on PPH all over the India, and she has attained many awards. Over to you, Shashi Kabra, ma'am, for an important discussion on internal iliac artery ligation, which I think each and every obstetrician must know to prevent the maternal mortality, both for the obstetrics and in the gynae procedures. Over to you, ma'am.
Thank you so much, Dr. Samta, for such a kind introduction. And thank you so much, Dr. Sadhana Gupta, ma'am, Dr. Babita, Dr. Ayush Agarwal, for always keeping my lecture in your programs. And my special thanks to the societies of Greater Noida, Moradabad, Bareilly, Bulandshahr, and Shahjahanpur. So I am sharing my screen. So is my screen visible?
Ma'am, your screen is visible.
Is it visible?
Yes, ma'am.
Yes, ma'am.
Yeah.
Visible
So
and
we are
you're clear.
talking about... Hello, yes?
Ma'am, you're clearly audible and screen is visible.
Oh, very good, very good. So I will talk about step-wise vascularization in the management of postpartum hemorrhage. All of you know that it is a dreaded condition and PPH is a fastest killer. So इस बीमारी को हम कैसे जीतेंगे? How will win PPH? By it should not be a nightmare. We should convert our nightmare to an expertise. तो nightmare को expertise में कैसे convert करेंगे? By learning the skills of performing every type of operation for managing PPH. So this is one part of that only. I always say that an obstetrician should remove the word nightmare from her or his dictionary, and we should repress the word nightmare from the word expertise. So first, coming to the first part of stepwise devascularization, all of you know that we ligate at two places. One is uterine artery, upper and lower, and second is utero-ovarian anastomosis. So this is the LSCS site, and we ligate the uterine artery at these two places. And this is the site for ligation of utero-ovarian anastomosis. Actually, it is said that it is ovarian artery ligation. We are not ligating here. We are ligating here, basically a branch of ovarian artery and one ascending branch of uterine artery. And the anastomosis lies in the broad ligament. So as it is a video session, I am showing you the video of uterine artery ligation. It is self-explanatory. Bladder dissected down, palpating the uterine artery. I take either number 1 chromic catgut or vicryl. So take a bite at 2 centimeter taking chunk of 2 centimeter of myometrium, and from anterior to posterior, the needle goes. The suture material I use is number 1 vicryl or catgut. So we just fan out the broad ligament and take out the needle through the avascular window in the broad ligament, so as not to injure any bigger vein or vessel. Needle taken out anteriorly. The suture material here I am using is number 1 vicryl. Tie the knot securely. There should be 2 turns in the first knot. Again, I am repeating, there should be 2 turns in the first knot. Then make a complete surgical knot. And this is the site for distal ligation, which is 2 to 3 centimeter below the proximal one. Method is same. Take a 2 centimeter chunk of myometrium from anterior to posterior. Then go from posterior to anterior by fanning out the broad ligament and pass the needle through a vascular window in the broad ligament. We have to take out this carefully, because if we puncture a vein, there can be a hematoma formation. And similarly, just tie it. Remember one thing, uterine artery ligation is to be done bilaterally. Because if we ligate the unilateral uterine artery, then bleeding will still continue or our purpose will not be solved. So, coming to uterine ovarian anastomosis ligation, this video is shared to me by my friend, Dr. Soba. You see here, chunk of myometrium is taken. Site is this, not this one, because if you prick it here, then it will cause a lot of bleeding. So, I'm here using number 1 0, vicryl or catgut. So, needle pass from anterior to posterior, knife from posterior to anterior, you just see. Basically, it is covering the anastomosis in between 2 bites. Two turns clearly seen in the first knot. So this is how utero-ovarian anastomosis ligation is performed, to be done bilaterally. Now coming to the most important part. Now the RCOG guideline on postpartum hemorrhage 2022 recommends it clearly that every obstetrician should know how to perform internal iliac artery ligation. You know that the facility of uterine artery embolization is not available in many parts of India, and it is not expected that it will become so popular in coming 10 to 20 years, because it needs a big infrastructure and 24 hours availability of a radiologist. So it is usually said that 1 in hand is better than 2 in bushes. So please learn the skill. If as an obstetrician you know internal iliac artery ligation, then you can save many patients at that particular time. So coming to our anatomy classes, this is abdominal aorta, the biggest vessel in our body, divided into 2 big vessels at the level of L4 and L5, the 2 common iliac arteries, and here it makes an inverted Y. And then again, each common iliac artery divides at the level of sacroiliac joint into 2. One medial smaller diameter, that is internal iliac artery, which goes posteromedially, and lateral external iliac artery, which continues below the inguinal ligament as femoral artery. And this in turn makes 2 inverted Y again. So when we talk about inverted Y, we are concerned with this inverted Y. So this is an inset of the same picture. This is the lateral side. This is the medial side. You see here, this common iliac artery divides into external iliac and internal iliac. Internal iliac artery, as soon as it originates, it gives the posterior branch, which supplies the parietal part of the pelvis. So we have to ligate the internal iliac artery. So in the pool of blood, this posterior divisor is dorsal. So we ligate it at a place which is around 3 to 4 centimeter from the origin of the internal iliac artery from common iliac artery. I will tell you how to measure this distance in my next slide. So first, let's come to know the mechanism of action of internal iliac artery. Bilateral ligation results in 85% reduction in pulse pressure and 50% reduction of blood flow. It converts an arterial flow into venous flow, and it facilitates coagulation. Bleeding is reduced. In fact, I have seen many times dramatic changes with the bilateral ligation of internal iliac artery. Life is saved. It is initially technically difficult, but it has not a long learning curve. So you can easily learn it in 3 to 5-7 cases. So there are two approaches of performing this operation. One is anterior approach, where we open the retroperitoneum from the cut end or peritoneum of round ligament to lateral pelvic wall. Basically, we are opening the anterior of the layer of the round ligament peritoneum, and this is called, in general language, open the retroperitoneum. And the posterior approach is when we open the retroperitoneum 2 centimeters below and 2 centimeters lateral to the sacral promontory on both the sides, because they are the areas where the big vessels lie. And for this, we have to pull the uterus anteriorly. So these are my two important assistants in performing internal iliac artery ligation. This is mixture or right angle forceps, and this is a double thread. I use number 1 silk, and if silk is not available, I use number 1 Vicryl. I make it double. My sister always make it double, and she hands over me this loop. It is around 10 to 15 centimeter length on both the sides. So this is a teaching model which I made for my students, because when in real cases I ask them to assist me, then they just do not, they cannot properly assist, because they do not know the structures. They have never seen these structures in the depth of abdomen. So it is better that we should sensitize them. So I made a model for them which shows the anatomy and the technique. So please just go through this. This is common iliac artery. This is external iliac artery, which is later on continued as femoral artery. This is internal iliac artery, and we have to ligate the anterior division of the internal iliac artery. When we apply pressure on the external iliac artery and press it, then the femoral pulse will go. Normally in the pool of blood, this posterior division is not seen. If I place my thumb here, then the length of my folded thumb is around 3 centimeters. So I just put my thumb here at the beginning of the bifurcation, and around 3 centimeters, this is the place where I can recognize the internal iliac artery needs to be ligated. This is right angle forceps, also called mixture forceps. It is bent at 90 degrees and it has a point, but it is not sharp. I use only this instrument for dissection and for ligation. Internal iliac artery, this is internal iliac vein. They are enclosed in a sheath. So in order to ligate the internal iliac artery, we have to remove the part of the sheath. Now I do not remove the sheath along the whole length of the internal iliac artery. I remove the sheath only at the place where I need to ligate the internal iliac artery. And look at the movement. Here I am separating the sheath because this is my proposed site of ligation, and my movement will be like this, parallel to the sheath. Never do like this, because it will end up injuring the internal iliac vein below, and that will be a massive bleeding. So I am separating it like this. I have already made a place here for ligation, passing the right angle forceps from lateral. You can see the double thread coming, and gently I will open it, and I will get hold of the loop, and just gently I will come out like this. So now you understand the purpose of double thread. This movement is very, very gentle. In one movement we can make 2 threads. The chances of injury decreased. And make 2 threads. Thread. And this is another thread. See, this is plain and this is another thread. So look at the technique of applying ligature. I have taken hold of one ligature. I am not pulling the artery. If I pull the artery, then it will just get torn and will come in my hand, and there will be massive bleeding. So I am giving respect to the artery, going up to the superior surface of the artery and just applying knot. This is one turn and this is second turn, and I have tied it here. Then very gently I applied the second throw, and again very gently I applied the third throw. Without pulling the artery, I myself cut this. Just without giving any pull on the suture, I'll cut this. I'm just putting this. So this is. So anyone whoever learns and practices on this model is better able to assist in live case. So I'm just sharing one case. This was a 26-year-old primary Gravida with full-term pregnancy, booked initially in one facility. She had ANC care at some Anganwadi center and had labor pain on 23rd November and rushed to hospital at night. She went into obstructed labor, taken to another 4th hospital, undergone emergency LSCR for second stage arrest under spinal anesthesia. And remember the time, 8 a.m. in the morning. She had an episode of PPH at 10:15 a.m., which was managed medically. Then again, she had another episode of PPH at 12:30 p.m. She developed shock. So the doctors over there took her to the maternity OT, and her left lateral cervical tear was repaired. And there was also posterior vault repair, which was repaired under saddle block anesthesia. And during this time, she received 4 units of PRBCs, 4 units of FFP, and 2 platelets. Then after 11 hours at 7:15 p.m., she again went into shock. And this time the patient was resuscitated and referred to me. So when I received her, the pulse was 146 and BP was 104/60. But you see here, her shock index was more than 1. So I took no time in taking the decision that I have to open the abdomen in this case. And there was bleeding on vagina, but I did not waste time in exploring the vagina. So on opening the abdomen by right paramedian incision, that's a longitudinal incision is preferred in these cases. I saw this, there was a huge broad ligament hematoma extending right from the top of the fundus to the colpus. And that's why there was a tear in the vaginal vault. So I had to do a obstetric hysterectomy in this case. And after doing obstetric hysterectomy, there was still oozing in the pelvis because one side uterine artery got retracted. Usually in broad ligament hematoma, the uterine artery, if it gets retracted, it cannot be got hold, and in that case we have to perform internal iliac artery ligation. And this operation I did at 9 to 11 p.m. night when no great facility is available. So if you know the operation, then you can save the patient. So I'm showing a video of the surgery. Uterus is already removed, and this is round ligament pedicle. From there, I'm trying to open the retroperitoneum, one layer, and I will move towards the lateral pelvic wall, parallel to the infundibulopelvic pelvic ligament. You see, very carefully, I am lifting the peritoneum only, saving the structures below. My movement is from the round ligament to the lateral pelvic wall. Now I've kept all the instruments, and this is the loose areolar tissue, which I'm separating from only with my 2 fingers. You see here, this is the ureter in the medial flap. This is internal iliac artery. This is external iliac artery, and this is common iliac artery. So this is the inverted Y, which you have to recognize. Unless we recognize any structure, we should not perform any operation. Again, I am showing ureter in the medial flap, common iliac artery, external iliac artery, internal iliac artery, and ureter in the medial flap. Common iliac, internal iliac, external iliac, ureter in the medial flap. Now I am making it more proper. So clear-cut inverted Y is seen. Now I am pressing the external iliac and trying to feel the femoral. The pulse will go, and when I leave the pressure, pulse will come again. Now I'm here pressing the internal iliac artery. There will be no change in femoral pulsation. Now look at the dissection, which I'm doing. As I've told you in my model, I do dissection with the mixture forceps and separating the sheath which encloses the internal iliac vein and internal iliac artery. The vein is below. Very gently, my assistant cuts this part of the sheath. And the place for my ligature, as I've already told you, my half thumb length, that is 3 to 4 centimeters below the origin of the common iliac artery, internal iliac artery from common iliac artery. Because if we do along whole length, then the chances of injury to the internal iliac vein below will be increased with that much movements. So I'm dissecting and separating the sheath of the internal iliac artery and vein, and the movement is parallel. Now I've made the place, and I'm passing my mixture forceps from lateral to medial. On both the sides, it is from lateral to medial, and loop is ready beforehand. Loop should always be made ready beforehand, and I will pull it on the other side. We pass the mixture forceps from lateral to medial, not from medial to lateral, because if we pass it from medial to lateral, then it will hit the external iliac vein and injure on that side. So now I made I've cut the loop and I made 2 threads as I've shown in my model. So now you can well understand that someone who practices on the model can learn it easily and can assist better, because it is always done in a grave emergency. So now I'm trying to separate the threads, which one belongs to which one. Very gentle movement. I never pull the artery. I keep utmost level of patience. लोग कहते हैं कि PPH को मैनेज करते हुए दिमाग खीरे की तरह ठंडा होना चाहिए. मैं कहता हूँ कि PPH को मैनेज करते हुए दिमाग आइस की तरह ठंडा होना चाहिए. And I'm taking 2 turns. I'm bending my neck, bowing my head and bending my back. And I've applied the suture on the superior surface of the internal iliac artery. मेरी कमर झुक गई है, सिर झुक गया है. आर्टरी आपको सलाम करते हैं. We salute you. You are one of the biggest vessels of our body. Then second knot I've applied. Any time I will not pull. And the knot plays third time. My fingers are going up to the artery. I will not pull. So first ligature applied and being cut. I myself cut my sutures because I know how to pull it, how much pressure I have to give on pulling. Now, the second suture is to be applied 0.5 to 1 centimeter away from the first. Now I have only 1 thread in hand. I made the knot outside, taking 2 turns. Now I bend my back, bowed my head, and took my fingers deep into the cavity and placing the knot directly on the superior surface of the artery. You can see a bulge in between the 2 ligatures. So now you can see this is the internal iliac artery with the ligature. This is external iliac artery. This is common iliac artery. And here is the ureter in the medial flap. So the technique of pushing right angle force, passing right angle forces always from lateral to medial. Lateral to medial. Remember it on both the sides, lateral to medial. I perform internal iliac artery ligation only on standing one side. And the movement of this is always from lateral to medial. Remember the word. So these are my own tips for ligating internal iliac artery, that when you open the retroperitoneum, then you open it from the round ligament. When it is cut, you can go through the cut end, or when it is not cut, then you make a nick and move the scissors towards the infotubral pelvic ligament, because it goes to the lateral pelvic wall. So we'll give you direction. Then if you do posteriorly, then 2 centimeters below, 2 centimeters lateral to sacral promontory, you can open the retroperitoneum by lifting it with artery forceps. And once you open the retroperitoneum by 5 to 6 centimeters, then always do finger dissection. There should not be any instrument in your hand. Otherwise, that instrument in hand will prick in that area and will cause bleeding, injuring the vessels. Then one most important thing is locate the bifurcation. I've shown you beautifully how to recognize the bifurcation. That is the inverted Y we were talking about. Then recognize the internal iliac artery as a medial structure, not causing any change in femoral pulse. It is the external iliac artery which causes change in femoral pulse, because external arteries, iliac artery is continued as femoral artery. Then movement of mixture forces always from lateral to medial. Then careful knot tying in the cavity, no pulling. And then 2 ligatures 0.5 to 1 centimeter apart, I've shown you. And remember my last words, always do bilateral, because the chances of re-laparotomy and morbidity increases if we do unilateral. So with this, lots of thanks for giving me this opportunity. My best wishes to Dr. Sadhna ma'am for her presidential election, and I myself seek your valuable vote. Request to cast a 1 vote in my favor for ICOG Governing Council membership, which starts on 1st September and ends on 10th September. Thank you so much.
So we would like inputs of our chairpersons. Ma'am, as usual, did a very rocking job. I simply enjoy the video every time I see it.
Thank you so much. Thank you so much.
It was an excellent presentation. One question I would like to ask. I am also doing internal iliac artery ligation,
Yes, ma'am.
but I always find the first approach easy in comparison to the posterior approach. Ma'am, what is your take on it? Interior, I always am able to locate very easily. But whenever I have tried the posterior approach, then it is slightly becomes difficult for me to locate the bifurcation and all. So any tip exactly, what I was reading was that you try to locate the uterosacral ligaments and then below it just give a nick, because at that place the ureter is going to lie over that structure. So is it any other tip you can give for the posterior approach?
Yeah, madam. I personally myself prefer anterior approach. It is always easy. Remember it. It is always easy. You can see the round ligament, and from the round ligament you can move up to the lateral pelvic wall. So where it is usually said that when you want to do a surgery successfully, then you do that approach with which you are familiar with, or which is easier for you. So my first advice is that if you like the anterior approach, you go on continuing with the anterior approach. You are at least doing internal iliac artery ligation and solving the purpose. So, and regarding, usually in most of the cases I could do in through anterior approach. In few cases, in 2 to 3 cases, I did from posterior approach. So there is little difficulty. First thing is that you need somebody to pull the uterus on the front side. Then the gut has to be pushed back and upwards. But you always palpate the sacral promontory, go up to the lateral ends of the sacral promontory, and exactly you measure 2 centimeter lateral and 2 centimeter below, and lift the peritoneum over there. There is not, the uterosacral ligament is not there. And then you make a nick, as when we open the abdominal peritoneum, we lift with 2 artery forceps and make a nick. And then under under your visual inspection, you cut the retroperitoneum. What is visual inspection? You cut it and you see that you are not ignoring any structure below. So that is the method. Exactly.
But exactly, ma'am, we should know it, because sometimes in cases of severe endometriosis, in cases of gynae surgery, sometimes we require when we are doing a
Yes. So this is the correct method.
approach
That you
is
just
more
you lift the peritoneum in between 2 arteries, make a nick, and once you make a nick, then you can see, you can visualize, and then you go on cutting it.
So, ma'am, you have beautifully described and demonstrated the stepwise devascularization patterns, and it is very useful manuals where we want to conserve the fertility and to conserve the uterus also. So, very beautiful depiction, ma'am.
Thank you. Thank you.
Well. Two, three
so
more steps you have stressed over there. That middle, lateral to middle, it should be this
always
mixture.
lateral to middle.
Yeah, and the point where we have to give the nick is very important. Thank you, ma'am. Thank you, ma'am, very much.
Thank you. Because you have to recognize a place where you have to pass the mixture forceps, because the length is this much. So if you're along the whole length, every point you are introducing it, then every time you are increasing the chances of injuring the internal iliac when it is lying below. So make one point where you have to pass that mixture forceps, and always remember the word lateral, because you can stand on any side. So remember the word lateral to medial rather than left to right or right to left. Okay, lateral to medial.
If in case any of the vein is lacerated while passing, so apart from packing, any other thing at that time, what you can
Keep
do?
a bulldog clamp always ready. And in the beginning, you can inform your surgeon colleagues that I'm doing this and this operation. And then there is much, if it is cannot be controlled with packing, then just apply the bulldog clamp on the vein. And in the meantime, you inform your surgical colleague, they will come, make available number 3050 proline already beforehand. So they will just suture it and it will be okay. But what I want to put stress on the fact is that every obstetrician, whoever is conducting delivery, must learn. It is really a life-saving operation. जब मैं ओटी में काम कर रही हूँ रात को 1 या 2 बजे, सुबह मैं कहाँ रेडियोलॉजिस्ट को खोजूं, कहाँ किसको करूं, कहाँ किसको बुलाऊं. यदि आपको तो पता है कि the uterine artery bleeds 800 ml per minute, 5 से 10 मिनट में पूरा पेशेंट मर जाएगा. तो आपको तो उसी समय करना है काम. तो आपको अपना यदि स्किल है तो आप करिए और पेशेंट को बचाइए. So this is the reason
बहुत
behind
अच्छा,
it.
बहुत सुंदर। अभी तो आपने ये जो दिया ना, ये टिप्स बहुत very nice, and it is L to L. What I always L to L. So there's no way that L to L we have to go. और ये आपने बिल्कुल सही है कि like in practical setting हम लोग किसी को बुला नहीं सकते हैं बिल्कुल रात के 2 बजे।
आप
वो
किसी
लोग
को
भी आधा
बुलाते
घंटा
हो
लगाएंगे आने में, like they will come. So that is the thing, and इसी मिशन के संग हम लोग आगे बढ़ रहे हैं कि
Yes, yes.
जैसे लोगों का कि वो इतना मुश्किल नहीं है, just you have to learn the tricks of it और कहाँ पे key points हैं. So thank you, Samta, for Gayatri, all wonderful interaction we had, and hope it will be. Thank you. And once again, Sadhna, Samta, Aradhana, Shweta, Manisha, Dipali, Mridula, Gayatri, Pramila, Indu, Deepa, and Monica for being us together. And we look really forward, or always we learn, and all faculties and the dignitaries. So Babita, I think आप कहीं party में है? नहीं?
Ma'am, thank you.
You know, whenever you prevent a maternal mortality, you feel so good, and you always love to celebrate this.
हम सोच सकते हैं कि जो भी हमने सब लोगों के संग मिलके, लाइक कितनी बार मैंने शारदा इंस्टीट्यूट में हम लोगों ने कितना वर्कशॉप किया है, जेस्टोसिस, एचडीपी, so many times like na we have done something, and we are somewhere of course, और बहुत लंबा सफर करना है। खासतौर से हमको कुछ जो रीजनल बेल्ट्स है, रीजनल वेरिएशन है, नॉर्थ ईस्ट में, नॉर्थ में एरियाज हैं, यूपी में एरियाज हैं, पंजाब में एरियाज हैं, इवन हरियाणा में, वी हैव टू लाइक फोकस ऑन all these reasons so we can really make a difference. So everyone, and thank you Aradhana again.
Thank you for making us part. मजा आया thoroughly.
Thank you, ma'am, for inviting us for such a beautiful webinar.
Thank you, Shweta. Thank you, Shweta. So it is
And
all
best wishes, ma'am.
Yeah, all the best, ma'am. We are with you.
इलेक्शन
wishes,
बहुत
ma'am.
नजदीक है। थैंक यू शशि, इलेक्शन बहुत नजदीक है।
मैम आपने बहुत मेहनत करी और हम आपको
कोई
देखना
भी
चाहते हैं
हमारा
हाईएस्ट
मिस
पोजीशन
नहीं
पे।
होना चाहिए। यस यस थैंक यू, थैंक्स अ लॉट, थैंक्स अ लॉट। बबीता, आप वोट ऑफ थैंक्स
Yes,
दोगे?
ma'am.
यस गुड।
I want to thank you, ma'am. So it was a wonderful webinar. My sincerest thanks to our key organizer, Dr. Sadhana Gupta, ma'am. And I would like to remind once again, madam is the most deserving Foxy presidential candidate for the year 23. I request all of you to not only vote for her, but also motivate other people from your society to kindly vote for ma'am. It will make a
All
big
members.
difference. Yes, it
Other
will
than
make a
all
big
members.
difference. Yes, all members, all your friends, everyone that you know. And I would like to thank our chief guest, Dr. Anuradha Khanna ma'am, and our guest of honor, Dr. Richa Singh. Yes, they took out time from their busy schedule and they gave us some really wise inputs today. I would also like to thank all our speakers, Dr. Sadhana ma'am, Dr. Samarth Ram, Dr. Shashi Kabra ma'am. Ma'am had to really wait till the end to complete the
No
session.
problem,
We're really
no
sorry,
problem.
ma'am, for you had to give so much
No
of time.
problem.
Yes, ma'am. And I would like to thank all our chairpersons for today's session, Dr. Rakhi Singh, Dr. Sadhana Jaiswal, Dr. Kanchan Prasad, Dr. Punita Agarwal, Dr. Mridula Sharma, Dr. Aradhana Singh, Dr. Shweta Mathur, Dr. Manisha Jain, Dr. Santa, and Dr. Gayatri Singh. Yes, you all conducted the session so very smoothly and all had given some inputs from their own side. I would also like to thank our moderators for today, Dr. Jyotsna Suri and Dr. Shiva Marwa. They had a meeting today, but yet they conducted the session so very nicely. Not to forget our panelists who gave they really worked hard for this panel and they gave some really, they made it really very interesting. Dr. Chitra Setia ma'am as an expert panelist was really wonderful. And our panelists, Dr. Punita, Dr. Pragati Agarwal, Dr. Anubha Agarwal, Dr. Alpana Agarwal, and Dr. Deepa Saxena, all of them were really wonderful today. Not to forget to thank my co-convener, Dr. Ayushi Agarwal. She works very hard every time behind the scene. So I must thank her. And the IT support from Sahiti and Tulika. Without their support, our webinars can never be successful. It was a grand webinar on the whole. And again, before concluding, my sincerest request to kindly vote for Dr. Sadhana Gupta, ma'am.
we really want to see in her in the highest post of faculty.